Well, good morning and welcome to the 10th hearing of Portfolio Committee number 2's inquiry to health outcomes and access to health and hospital services in rural, regional and remote New South Wales. My name is Greg Donnelly and I am the chair of the committee. The inquiry is examining health outcomes, access to services, patient experience, planning and capital expenditure in rural, regional and remote New South Wales. Before I commence, I'd like to acknowledge the Gadigal people, who are the traditional custodians of the land on which this parliament sits, and I would like to pay respects to elders past, present and emerging of the Eora Nation and extend that respect to other Aboriginals who may be viewing the broadcast over the course of the day. We welcome you. Today's hearing is being conducted virtually. This enables the work of the committee to continue during the COVID-19 pandemic without compromising the health and safety of members, witnesses and staff. As we break new ground with the technology, I would ask for everyone's patience through any technical difficulties we may encounter over the course of today. If participants for some reason lose their internet connection and are disconnected from the virtual hearing, may I ask them to rejoin the hearing by using the same link as provided to you by the committee secretariat. Today we will be hearing from a number of stakeholders, including peak cancer organisations, the New South Wales Medical Staff Executive Council and research organisations. I thank everyone for making the time to give evidence to our public hearing today. Before we commence, I would like to make some brief comments about the procedures for today's hearing. While parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside of their evidence at the virtual hearing. I therefore urge witnesses to be careful about comments you may make to the media or others after you've completed your evidence today before the inquiry. Committee members, committee hearings, I should say, are not intended to provide a forum for people to make adverse reflections about others under the protection of parliamentary privilege. In that regard, it is important that witnesses focus on the issues raised by the inquiry's terms of reference and avoid naming individuals unnecessarily. All witnesses have a right to procedural fairness, according to the Procedural Fairness Resolution adopted by the Legislative Council in 2018. There may be some questions that a witness could only answer if they had more time or with certain documents to hand. Accordingly, witnesses will be advised that they can take a question on notice and provide an answer within 21 days. And finally, today's proceedings are being streamed live and a transcript will be placed on the committee's website once it becomes available. Finally, a few notes on virtual hearing etiquette to minimise disruption and assist our Hansard reporters. Can I ask committee members to clearly identify who questions are directed to, and could I ask everyone to please state their name when they begin speaking? Could everyone please mute their microphones when they're not speaking? Please remember to turn your microphones back on when you're getting ready to speak. If you start speaking whilst muted, please start your question or answer again so it can be recorded in the transcript. Members and witnesses should avoid speaking over each other so everyone can be heard clearly. And finally, also to assess Hansard, may I remind members and witnesses to speak directly into the microphone and avoid making comments when your head is turned away. Well, once again, thank you everyone who's joining us on the internet today. And we'll now proceed with our first set of witnesses for the public hearing this morning. What I will do is that I'll move through the witnesses, seeking from each of you to state your name, your full name, your position title, upon which you are appearing before the inquiry today, and swear either an oath or affirmation, whichever you choose, and the words should be before you. They ought to have been provided, but if for some reason they haven't made it, just let us know and your choice will be respected and the words provided to you. So I'll go through our first set of witnesses this morning. And I have an order here that's been placed before me. So it's not in terms of priority or any other fashion, just the list. So the first person is Ms. Phillips. Could you please proceed?
Good morning, I'm Emma Phillips and I'm the Executive Director of Can Assist. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you very much, Ms. Phillips. Ms. Gallagher.
Yes, good morning everyone. Magella Gallagher, Relationship Manager, Can Assist. And I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much. Mr. Mitchell.
My name is Jeff Mitchell. I'm the Chief Executive Officer of Cancer Council New South Wales, and I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much. And Ms. Miller.
Good morning, Annie Miller, Director of Cancer Information and Support Services at Cancer Council New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And once again, thank you to the four of you who I know are very busy with your respective responsibilities with your organisations, and we appreciate you carving out some time and making yourselves available today for our public hearing. Before we commence, can I just note and thank, first of all, Can Assist with respect to the submissions that have been received. We've received what is the first submission that came in, which is submission number 34 to the inquiry. And then we subsequently received a submission from you, Ms. Gallagher, as the relationship manager, and that stands as submission number 710. So Can Assist have effectively two submissions before us, and we thank you very much for those. They can be taken as read by the committee. And if we move then to Cancer Council New South Wales, thank you very much for being available today. And I just note for the record, the receipt and the processing of your submission, it stands as submission 173 to the inquiry, and as with Can Assist, has been processed and uploaded onto the web page for the inquiry and stands as evidence to the inquiry. What I'll do before we move to questioning is ask both organisations to make an opening statement. I'm not quite sure who will make it. With respect to Can Assist, noting that they've got two separate submissions, I will invite an opportunity for both participants to say a few words, but in both cases for each organisation, if we can keep the opening statements to a few minutes, which will maximise the opportunity for the committee members to proceed with its questions. So are people happy with that format that we proceed with? Wonderful. So we'll commence with Can Assist, and Ms. Phillips, may I invite you to make an opening statement?
On behalf of Can Assist and our 3,000 statewide volunteers, I thank the committee for the opportunity to provide our perspective. Our submission focuses on three key areas of concern. Firstly, IPTAS. A highly visible and widely accessible travel and accommodation scheme must be the centrepiece of any vision for better health outcomes for rural, regional and remote Australians. However, our anecdotal and quantitative intelligence, as reported in the tabled IPTAS document, overwhelmingly tells us that most patients are unaware of the scheme and almost all patients find the forms too complex to navigate. For those that do persevere, rebates are inadequate. Travel and not-for-profit accommodation rebates have been static since 2015. Accommodation facilities like ours in Wagga Wagga offer a key gateway into the regional health system and for the most part have carried an ever-increasing expense base. This is not sustainable. Can Assist and the Regional Accommodation Providers Group recently met with Stephanie Williams and 3 of her colleagues from New South Wales Health. Our IPTAS concerns and remedies were heard. though there is little that can be done without additional budget. A further concern is that despite Minister Hazzard's declaration as per the Hansard on February the 11th that he was happy to instruct Health to look at the issues, they have received no such instruction. Secondly, radiotherapy, access and viability. Recipients of ours, Danielle and Tony, made 132 trips over 2.5 years, travelling around 24,000 kilometres seeking treatment for their 7-year-old daughter, Hayley. 74% of this travel related to radiotherapy treatment. Whilst the treatment itself is often short as 15 minutes, the frequency, length of treatment, and its delivery as an outpatient makes it uniquely expensive for those that don't live close to these services. The indirect impacts are financially devastating. In Hayley's case, Mum stopped full-time work, Dad dropped back to 2 days a week, and Hayley's grandmother left her part-time job. The federal government has promised $35 million to help build an additional 7 radiotherapy sites throughout country New South Wales. For these services to be viable at no out-of-pocket cost for local residents, the New South Wales state government must be prepared to either operate them themselves or be willing to provide a reasonable co-payment to private operators. The state government makes these co-payments in metro areas, and this approach is routinely practiced in other states across Australia. As far as we know, New South Wales Health has refused all partnership proposals. 4 of the 7 grants remain unawarded. Why leave federal grant money on the table and deny equitable access to treatment? And finally, staffing issues, under-resourced and undervalued. GPs are where it all begins, yet our communities wait too long, some up to 4 weeks to access what is often a junior GP. In Hayley's town, the long-term doctors had closed their books. Medical clinics with less experienced staff were her only alternative. Kudos to her mum, who trusted her gut and persisted when 3 separate doctors over 3 separate appointments told her not to worry and sent her home. Hayley was later diagnosed with brain cancer. Specialists are even scarcer. Social workers offer a vital service. Their caseloads are exploding and they are stretched across the spectrum of care. Sadly, many of their contracts are only 1 year, despite years of experience and commitment. Many of our volunteers have inappropriately become quasi-social workers, filling these gaps. Thank you.
Thank you very much for that very detailed and clear opening statement. Thank you. Thank you, Ms. Phillips. Can I ask Ms. Gallagher, would you like to make an opening statement?
Chair, we wrote that speech with a view to both of our submissions.
No, that's fine.
I won't add anything, only just to check that you actually received the additional document also around the presentation that we gave to New South Wales Health. So you should have the 2 submissions, and there was also a PDF document that you hopefully received as well. You didn't mention.
Yes, thank you very much.
Oh, good. Okay.
Confirm that has been received, and thank you very much. That augments very nicely the material we have already, and no doubt the evidence we'll hear from both of you this morning. So thank you, Ms. Garrett. Can now move to the Cancer Council, and Mr. Mitchell, as the CEO, will you be giving the opening statement?
Yes, I will. Thanks, Chair.
Please proceed.
So firstly, I'd like to acknowledge the traditional custodians on the land on which we meet. For me, that's the Wadi Wadi people of the Dharawal Nation down here in beautiful Kangaroo Valley. I'd also like to thank the committee for the opportunity to give evidence at the inquiry. Cancer contributes the largest burden of disease in Australia. In New South Wales, over 51,000 people are expected to be diagnosed with cancer, and over 16,000 will die of cancer in 2022, more than stroke and heart disease combined. Cancer outcomes in New South Wales are among the best in the world, yet for people living in rural and remote New South Wales, outcomes remain poor compared to people living in metropolitan areas. There has been little progress in narrowing this gap in the past 20 years. Everyone with cancer deserves the best chance of living well, and yet evidence clearly demonstrates that the chance of being diagnosed with cancer and dying from cancer increases with distance from major centres. Unfortunately, the reality is that a person's experience of cancer is a postcode lottery. For people with cancer in regional New South Wales, a host of issues affect whether they can access the best possible cancer treatment and care when they need it. One of the clearest things that we hear from people we assist is that they did not expect a cancer diagnosis to be so expensive. The out-of-pocket costs faced by people with cancer are higher for people outside metropolitan areas. So much so that 1 in 5 people with cancer in regional New South Wales report that they skip health appointments because of the cost. People in regional New South Wales are less likely to have access to a nearby public hospital. And for those that cannot be treated locally, travelling to and from treatment and staying away from home comes at an enormous physical, emotional, and financial toll. Access to supportive care services can be limited in regional New South Wales, and people with cancer can struggle to navigate the system, which is fragmented across different providers and locations. Cancer Council New South Wales works closely with people affected by cancer in regional New South Wales, providing essential services such as transport, emergency financial support, accommodation, information, and supportive care. Our recommendations are based on evidence from what we hear day to day, day in and day out, and from people affected by cancer. For this inquiry, we also heard from more than 300 people who responded to our Cancer in the Regions survey. Cancer Council New South Wales believes there are things that can be done by the New South Wales government quickly that will significantly improve the quality of life for people with cancer. People should not be forced to choose between getting cancer care or paying their bills. Lifting reimbursement rates for the Isolated Patient Travel Accommodation and Assistance Scheme, so-called IPTAS, and broadening its eligibility will go a long way to relieving this financial and emotional toll. Investing in care coordination will help prevent people from getting lost in the system by linking them to treatment options and the services that are available to support them. And importantly, we believe addressing out-of-pocket costs for cancer treatment will reduce inequality, because your postcode should not determine whether you can afford treatment or not. These inequalities don't just exist across the country and city divide. Out-of-pocket inequalities also exist between different regional communities. And finally, I think it's important to sound a warning about what lies ahead as we recover from what has been one of the greatest public health challenges in a century. COVID-19 has stopped many things, but it didn't stop cancer. The delays in screening, diagnosis, and interruptions to cancer care will see cases rise, we believe, quite sharply and for an extended period in the near future. And the nature of the cancers diagnosed are very likely to be more advanced. The lessons, or the other lessons from COVID-19, is that we need to urgently address the inequalities in our health system, inequalities that existed before the pandemic. If we don't have a plan to address the ongoing impact on access to cancer care and services, COVID-19 will only amplify those inequalities. Thank you, Chair.
Thank you, Mr. Mitchell. That was a very clear and helpful opening statement, which I'm sure will facilitate a number of questions. So thank you very much. We'll proceed now to questions from committee members. We have effectively about 10 minutes for each group around the table to take us through to around 11:15 or thereabouts. So we'll start with the opposition, the Honourable Walt Secord.
Thank you, Mr. Chair, and thank you for your opening statements. Evidence that the committee has heard over the last few months has been absolutely damning, involving rural and regional areas. Now, Mr. Mitchell, in your opening statement, to paraphrase, you said that cancer treatment in the city is probably the best in the world. How would you describe access to cancer treatment in rural and regional centres in New South Wales?
It's very dependent on what's available nearby.
Yep.
As we mentioned, quite often, I'm sure you'd understand that people are often required to travel distances and to stay away from their home. That affects all parts of the cancer journey. So it's starting with, access to screening, access to diagnosis in a timely manner, and then, of course, importantly, access to treatment and care. The availability of public facilities. One of the case studies we've looked at is that if you had breast cancer and you were based in Wagga, for example, you would need to access the Riverina Cancer Care Centre there, which is a privately owned facility. And your out-of-pocket costs for that treatment would be just short of $3,000 for what would be considered a normal course of treatment. Whereas if you were living in the lower North Shore, you would access Royal North Shore and there would be zero out-of-pocket costs. And I just don't think any of us should be comfortable that that situation is allowed to continue.
Now, are there significant variations even within the country? Because I understand in your submission on page 7, you talk about from Bathurst to Burke, Narooma to Narrabri, that there is clear evidence of higher cancer incidence, poor survival, and unwarranted variations in clinical care for people with cancer. Do you find that even within rural and regional areas, there are huge discrepancies in access to treatment, to cost, and to, I'm sorry to say, the survival rates?
Look, that's true. And there's a wealth of information that would support that hypothesis, even if you look at the Cancer Institute New South Wales outcomes that they track. You can see that cancer care, treatment outcomes, and indeed, ultimate health outcomes for patients across regional areas can vary quite widely.
Ms. Phillips, would you say that evidence or information to your organization is that would you say that rural and regional people, I don't know how to phrase this, but are dying unnecessarily or prematurely due to lack access to cancer treatment in rural and regional areas?
Whilst I don't have the evidence in front of me to give you the stats, I would say that the disparity in access, the further that you move away from a metro, would indicate that that would be the case, because we see people that come forward and ask for help, and it takes a lot for people to come forward to ask for help. We hear stories about the access just to get to a GP, like I tabled. And so how many people are not coming forward to a GP? I can't tell you, because they don't come to us. But I do see the issues with people just coming forward to us, and the feedback from the grassroots on the ground to how hard it is to get into a doctor. So I can only surmise that then echoes through to the entire spectrum of care that we see. And so people don't get the same opportunities as I do in the city with a bevy of choices around me.
Mr. Mitchell, so if there was okay, you talked about people skipping appointments. What do people say or tell you, like skipping a cancer treatment appointment? What does that involve emotionally, physically? How does it impact on the patients?
Look, if I may, I'd ask my colleague Annie Miller.
Okay, thank you.
To address that. I think she's got
thank you, Mr. Miller.
a clearer
great.
Yes, thank you, Ms. Miller.
Thank you very much. Yes, we hear everything from the very initial diagnosis from on our information and support line. For someone in the rural areas may say to us, I think I've just been diagnosed with cancer, but to be honest, I honestly can't afford to leave my property. I have a family to support, and they want me to go to the city, and I just can't afford it. So I've actually decided that I'm not going to go through with this, but I'd like to know my options. There's no one here locally that can help me. We can't afford to travel to the city and to stay in accommodation, and they choose not to be to follow through with treatment. That's their examples, but also going through. Sorry.
Sorry, can we continue? Yeah. I'm sorry. So you have examples of people who have cancer diagnosis.
Yes.
And because of distance, and costs and lack of rebates or insufficient rebates, they decide not to seek treatment.
That's right. That's right.
Yeah, Chair,
That's
could I just interrupt there? Sorry, Annie, just from a Can Assist perspective, because we've frequently had social workers and allied health workers tell us that if it wasn't for us, that people would not continue their treatment. And we've also had recipients who tell us directly that, you know, they would have had to have sold their houses had it not been for us, and they would not have been able to afford it. And I think it's all about cost, and the further you are from the treatment facility, the more it costs. And it's not just the travel and accommodation. Travel and accommodation is key. And if IPTAS was delivered better, more people would know about it. And when they're actually deciding whether or not to have treatment right back in the early stages, if people were more aware of the availability of IPTAS and what it could do for them, we do think that would help. But even notwithstanding IPTAS, the further away you are, you've got the travel and accommodation, which is obvious, but also because you're travelling outside of your family community, you're almost invariably having to take a carer with you. So that means you've got loss of two incomes. And when there's children involved, it often means, like as in our opening speech, you have extended family that also lose income. So there's indirect costs there that have to be considered, the actual travel and accommodation costs. And as Jeff pointed out, if you're unfortunate enough to be in the Murrumbidgee, you're exposed to the RCCC, which is the only private hospital, major regional hospital centre in rural regional New South Wales. There is a private-public partnership there, but it's not complete. So there are still out-of-pockets. And whilst we have private-public partnerships in metropolitan areas, and routinely across the country where out-of-pockets are zero, we don't have that in Wagga. So there's that additional medical issue as well.
Ms. Miller, can we go back to, so would you have many examples or cases of people deciding not to pursue treatment in rural and regional areas because of distance, but also because of costs and also lack of access to public facilities?
Yes, we do. I don't have the exact numbers, but we do. It's a theme that comes up regularly. May also say that we also speak with people who are going through treatment, and that might be an extended treatment, and they may get to the stage where they're starting to juggle what my bills are according to how many more follow-ups I need. So you know what, we're going to skip this follow-up, or we're going to skip the last 3 treatments because I'm feeling better, and it's actually better for my family and better for us psychologically if we don't have to keep traveling back to the city. Now
would there be would this be a handful? Would this be dozens?
No, it's a very regular. It's a very regular thing we hear. I also like to point out that there are many people on clinical trials nowadays, which are actually part of normal treatment, and IPTAS does not cover clinical trials. So there is a lot of decisions that people have to make. So often, depending on their cancer treatment and their type, they're offered a clinical trial, which may actually really benefit them. But they make that decision because IPTAS doesn't cover any travel and accommodation for clinical trials. They may make the decision that they're not going to try it. So they may or may not speak with their family and make that decision that that's where we can't really afford to it, because what if the trial doesn't work? We can't afford that. And as we said in our opening statement, it then becomes a postcode lottery.
So how do you support people who decide, because of cost, decide not to pursue treatment? What support do they receive, and how can they be supported, and what happens to them?
So the ones we can support that actually are willing to take our support, we can support them with travel and accommodation costs. We can support them with emergency financial assistance to pay some of their bills. We can support them with financial counselling to balance their budget and to look at how they can proceed with what they do have. We can support them with in a pro bono area of financial and legal assistance. So we can prepare wills, we can look into their superannuation, we can investigate insurance options. We provide psychosocial support through our information and support line, counselling for them and their families, peer support, so a wide breadth of information and support. What we absolutely want to do is support everyone we can to get to cancer treatment.
Thank you.
Thank you very much. That's most helpful evidence. Can we now proceed with questions from the crossbench, and I'll invite the Honourable Emma Hurst, Deputy Chair. Emma.
Wonderful. Thank you so much, Chair. Ms Phillips, in your opening statement, you mentioned that there was a 4-week wait for many people to see a doctor, and you also talked about the stretch for social workers as well. What are the waiting lists looking like to get a social worker to assist?
Oh, you may never even get a social worker being in touch with you. They are only working on points of a head count, so we're not talking a full-time equivalent. Social workers, the one that we talk to, stretch from first cancer diagnosis all the way through to palliative care. So they are dealing with the real emergency triage. So there's some people that may not even get to see a social worker. So that's where our volunteers are coming in, trying to direct them with some information of just where to go and who can help. It is such a lack. From the time I came into this role, our volunteers have cried out to say there are not enough social workers across the state. And the more we dig into it, it's their caseloads are just way too high. They don't see the numbers in their communities.
Yeah. In your submission as well, you talked about, or it seems like that there are a lot of community charities that are sort of having to fill in the gaps and to help pay for things like transport and accommodation. And we've heard from other witnesses that have come to this inquiry that they're really stretched, and they're particularly stretched at the moment because it's harder to fundraise for these things because of COVID, because of bushfires. Is that something that you are experiencing as well? And is it fair that charities are having to fill some of these gaps? What needs to be funded?
It certainly is not fair. I think why Can Assist resonates so strongly in rural New South Wales is that rural communities are a bit tired of having money leave the community. And I think we really resonate because they see their local money helping their local own. So they step out, and yes, our revenue's been down during COVID, but we've still had an immense amount of support, because I think that's what the charity stands for. It's about getting people this access, and they also know in their communities that they don't have that access. But you go to the extent, no, I touched on, we're in joint venture with Cancer Council down in Wagga Wagga. There are these not-for-profit organisations that are keeping their doors open from donations, from working to get grants, relying on, really, IPTAS has to keep those doors open. And it shouldn't be down to communities to be able to provide affordable accommodation for people who need to get to hospital. It really shouldn't be down to the charities. But thank God we have our volunteers.
Yeah, absolutely. Mr. Mitchell and Ms. Miller, in your submission, you talked about it being more cost effective to invest more in preventative healthcare measures. And this is something I'm quite passionate about. My background's in health psychology, and we looked a lot at prevention, and obviously there's very little funding in the prevention space. What health programs do you think would be most useful and should get more investment in the preventative space?
Perhaps I'll pick that up, Annie, and you might want to follow.
Thank you.
So there's no question that investment in prevention is a very worthwhile, and it's obvious of a worthwhile investment. And it takes many forms, and prevention campaigns at the state level and indeed at the federal level are important, and both, in our view, have been underfunded for a lengthy period of time. If you take, in the case of tobacco, still the largest killer when it comes in the most preventable in terms of cancer harm, etc. Anti-smoking or anti-tobacco campaigning, prevention campaigns have been underfunded for years and years, many years, as I say, at the state and federal level. Whether it goes to sun protection, whether it goes to nutrition, and then of course there's the national screening program. So prevention is important, but so is screening and early detection. You know, the earlier we can find cancers, really important. And if I could just tack on, just to support and reinforce the comments that Emma made about charities and costs, and particularly living through COVID. We're a large charity and very well supported. And fundraising is really challenging. It's challenging right across the economy at the moment for all charities, I think. Our revenues are down in fundraising, between 20 and 30%. It fluctuates. And so that's challenging on that side. But I think the important thing for us all to note is that we know that demand for our services, and this is all parts, but certainly across Cancer Council, is only going one way. And I mentioned about the potential surge in cancer diagnoses and also more serious diagnoses because of the likelihood of advanced cancers because of the delay. We know that the surge is going to affect demand for our services, and frankly our ability to continue to fund it year after year after year is going to be a significant challenge. And so the government clearly has a role to play here as well.
Absolutely.
So
Thank you very much.
Oh, sorry.
No, please proceed,
Oh,
Michelle.
I just wanted to add on to what Jeff said too. I think a lot of us always think about that it's the down and outs that put their hand out for help too. But I really want to table that the expenses across the spectrum. You could have someone that you think is asset and cash rich, but behind the doors they're not, and they're also calling out and they can fall through the cracks. So it's just not those people that we means test. It is a real spectrum of people that need help when it comes to a cancer diagnosis when you live in the bush.
Thank you very much.
Could I just add one thing too, Chair, just in relation to the comments around social workers? At Tamworth Hospital, for instance, the social workers there get 20 referrals a week. They only get to half. And as Emma said, the 20 referrals that they get are the people that are really in trouble. So, there'd be a whole lot of other people that are just never eligible for that service.
Thanks, Ms. Keller. That's very helpful piece of information. Kate Femin.
Thanks, Chair. Just keeping on this train of questioning. So what this kind of sounds like isn't kind of, we here in Australia, we've got Medicare and we've got public hospitals, and there's always a sense that you can get treatment if you need it because we're in Australia. We don't have a US-style healthcare system. But what you're all talking about in your submissions kind of sounds like that's almost what it is. But people are sick. They need treatment. They're going to die if they don't get treatment, and they don't get. We've got something. I think the stat says 20% of people are choosing not to get treatment. Is that so? It's kind of alarming. We've also got another submission here today that says by 2040, I think 88% of people in regional New South Wales will be over 65. So something really big has to happen in the next 20 years. Like if people are already refusing or can't get treatment because of costs. I might just go to you first, Ms. Phillips, just to get a response on that.
Okay, thank you. I think it's first of all, even before you talk about costs, it's actually just access to get a doctor. And that is just having a doctor on the ground and the support systems there. Put the cost aside. Then you start going down, a lot of people don't even appreciate the costs until they're on this journey. And it's then having to, again, put costs aside. It's leaving home, commuting, accommodation. It's all that other layer of just being overwhelmed when you get hit and being told that you've got cancer. So, I like to think that once people come in and get that treatment and that access, we're there to get you the access no matter where it takes you. But then you do start on this journey. No one cancer diagnosis seems to have the same dollar value against it. I can't sit here to tell you today and say, if you get breast cancer, this is what it's going to cost you, because depends where you go, who you see, public, private, where you live. And that's where this is just, it's great you guys are listening, but it's a bevy of different cuts that we can give you. Yeah.
Is anybody else? Ms. Miller, do you have a comment on that one as well?
Yes, I do. Thank you very much. I would like to point out that there is treatment for cancer has become amazing. Like, we shouldn't forget the just where we've come from just in the last couple of years, but the system isn't keeping up with it. So if you're diagnosed with a specific cancer where we know that a type of treatment is absolutely optimal and it is in a certain area, then that is what is recommended to someone. But for the layperson, when you go in and get diagnosed with cancer, the first thing you're going to think about is how much is this going to cost if you're living rurally, and how can I get access? And then everything else, your brain shuts down. So you can't actually even put the dots together. And I think the systems we've got, whilst we have touched on the fact that the outcomes in many cancers are fantastic, there is a disconnect between public-private. There's also a disconnect, and we hear from oncologists when they refer someone on, or a GP that may refer someone on to an oncologist, that GP or that specialist will often not communicate with their colleagues as to how much that's going to cost someone. So it's very clear in the clinical oncology conference late last year, there was a great amount of discussion about financial costs. And what was quite incredible, as an oncologist would say, I'm referring them on to have radiology, but I've never actually asked what that could cost. So the person doesn't know about what they might be out of pocket for. So we would really recommend that every medical professional signs on to use the informed financial consent. And that is so important upfront, to sit down with the patient to discuss what their costs are going to be. And that isn't happening very much.
Thank you. It's extraordinary, actually, that it's not happening, that's something that basic isn't happening. Oh, just quickly, I've probably got time for one last question.
Yeah,
I just
sure.
wanted to ask Cancer Council New South Wales. So, sorry, I've just lost sight of my screen. Maybe Mr. Mitchell, the first recommendation in your very comprehensive submission was the implement and embed the optimal care pathways. Like, I understand from your submission that it looks like, so Victoria has signed up to this, but New South Wales hasn't. Could you just explain to the committee a little bit about why we need to sign up to optimal care pathways, what that kind of incorporates, and why New South Wales hasn't signed up to it, what the history of that has been?
I'd have to take the last part of your question either on notice or perhaps ask Annie if she can elaborate. But in terms of the nub of the issue around providing patients with optimal care, so optimal care pathways, there's a huge amount of evidence and research go into how should you approach care, how should you provide care, and how can that be made clear to patients. And so we're involved along with other organisations in coming up with optimal care pathways. And as to why they're not or haven't been adopted or followed in New South Wales, I mean, I'd ask Annie if she can throw light on that, but otherwise I'd have to take it on notice.
Thanks, Jeff. And thanks, great question. I think we will take part of this question on notice, but I can say I think it's the way in New South Wales our health system is set up. So I think we don't have a framework that is overarching for all of the treatment centres. So it is very definitely a decision that's made by LGA and a treatment centre as to whether or not these will be embedded. But we really advocate that they are, but it's just our system is very different from Victoria.
Thank you very much.
Chair, sorry, excuse me. Could I just make a comment back on the prior issues around people skipping treatment?
Sure.
I just think that it's a multifaceted approach. There's lots of issues involved, but it's got to start with a better IPTAS. Because if people know right from the stage they get diagnosed that this scheme exists, if you look at that survey that we've conducted across our branches, across 6 local health districts, across all of our accommodation providers, you're talking about 60% of people who don't know about it. And then once they get it, you're talking about 90% of people, no matter where they are, that need help filling out these forms. So I think that that's a very practical thing that needs to be done, and there needs to be budget allocated towards that, not only to lift the rates, but to increase the awareness of the scheme and to make the form and the process far less complex. And as Jeff was saying before, widen the eligibility. That could make a very real, very quick difference.
Thank you very much, Ms. Coe. The Honourable Wes Fang. And Wes, I appreciate there's been some lengthy responses, so I'll provide you with additional time so we don't crimp your 10 minutes. So the Honourable Wes Fang.
Thank you, Chair. And to be honest, I think a lot of the questions that I was preparing to ask have been asked by some of the other members. So I probably won't use all of my time. But first, I wanted to start by thanking both of the organisations, and I've had numerous engagements with both of you in a number of factors, obviously in a professional role, but also my father, who passed away from cancer in Wagga, as it is a number of years ago, was very well supported by a number of organisations. And so I've had a lived experience, shall we say, with dealing with cancer in a regional setting. So I can very much thank both of the organisations for the work that they do. But I guess one of the things that I find interesting is the IPTAS issue. And I say this from somebody who does live in the regions and who does have multiple children who have had to travel for medical help, but also from somebody who has a background and a family's background in medicine. Even we struggle with navigating the IPTAS forms and the issues even with our experience. So from your perspective, what do you think it is that we can do around the application for and the granting of IPTAS to make it simpler and easier for people to access and understand what it is, how to get it, and that it's actually there? And I'll start with Can Assist, if I could, and then we'll move to the Cancer Council.
Yeah, I mean, look, we've done some, as I mentioned before, some surveys on it. And I think at the very basic, you need to have a more simplified form. Like if you're a patient in rural Australia that has to see a specialist more than once and you stay in one of our accommodation facilities, you've got to fill in 11 pages worth of forms. If you look at the VIPTAS form, which is the Victorian scheme, you only have to fill in 3 pages. And then when you look at the forms, we need double the amount of signatures of a place like Victoria. And often the initial signatures that you need, you don't find out about them until you're halfway through the process. So we actually have our volunteers running around to local GPs trying to get referral signatures. You know, 78-year-old Margaret from Tumut's doing 10 of these a week. And it's a similar story. So my first comment would be get rid of the referral signature. Victoria don't need it, we don't need it. Then you need to simplify the forms. There's so much repetition and it's so overwhelming for people. And also the terms aren't explained. Like, what's an authorised representative? That's who's got to sign it. Nobody knows who that is. So they're getting the specialist to sign it when really they don't need the specialist. And then there's things like this 200-kilometre cumulative rule that you're probably aware of. If you clock up that with multiple trips, that you're eligible, but that's not on the form. So nobody knows about it. It breaks our heart. We're telling these people all the time, apply, you're eligible. And then there's confusion about what specialists you can apply for, escorts. I mean, I could go on and on, but we would love to, our proposition to New South Wales Health is to sit down with a working group of people like us, like social workers, like patients, people who use these forms. Because the last time they changed them in 2017, they had form experts in, but they didn't bring the stakeholders in. So I think that would do it. If it was an easier process, it would promote itself. And then there's, look, I could go on, but it needs to be promoted. IPTAS have got a lot of good data out there. They know who's using it. They know who isn't. We should look at that data and work out who do we need to tell and how do we need to do it? And then we need to be monitored and evaluated on whether that is working, rather than just saying, we spent $25 million last year, it's working. That is not a benchmark.
Ms. Gallagher, would you agree that would be a good recommendation?
Absolutely. We need more budget to do this stuff because everything costs money.
Well, Chair, that was pretty much all that I really wanted to address. I mean, we can delve into how, you know, we could get more services into the bush, and I think those are more wider and complex issues. But I think to the point that both organisations have raised, that access to IPTAS will make a huge difference to not only cancer patients, but I think all rural and regional people accessing medical treatment. I think if there's one thing that this committee can do to assist, it will be to simplify that IPTAS process. And so I think you know, we can address a lot of the other questions you know, in further hearings or, you know, questions on notice at some other point, but that you've helped to address that IPTAS and highlight the importance and how to simplify it. I think both organisations, and noting my time has almost expired and we are due to finish shortly, I thank organisations for raising such an important issue.
Chair, can I just add, if I may, just briefly on IPTAS?
Yes, please.
I support the comments made, but as a government who wants to take care of the community, you really need to step back from this and think about, you know, why are there so many checks and balances and signatures and complexity put around a system that was put there with the intention of helping people who need the help? And so it's not only you know, the paucity of the assistance. When you look at, so, you know, one of the pieces that we looked at is if you're a New South Wales government employee, you're rightly reimbursed for travel, currently at the ATO rate, which is 72 cents per kilometre. IPTAS is currently 22 cents per kilometre. I mean, that disparity should shock us. But, you know, the overriding point around accessibility, simplicity, that comes from, well, what's the intent? And so I think, you know, as was suggested, sitting down with the people who use these forms, organisations like CanAssist and Cancer Council, social workers, treatment centres, etc., and completely redesign it so that it achieves its purpose, which is to assist people who need the help to get to treatment.
That is a very fair point, Mr. Mitchell, and it's obviously been made and clearly underlined, and I'm sure the committee members will be looking very closely at that. Can I take this opportunity to thank you all for participating today. Speaking for myself, but I'm sure all the committee members, it's been very fruitful hearing directly from two what are undoubtedly known as premier organisations in this state, particularly in the context of the work done through its volunteers. The good that you do to citizens of this state who reside outside, or both inside but outside the metropolitan areas, is incalculable. And we thank you all very much, and would ask you to pass our best wishes on to the officers, staff, the volunteers and supporters, because without that collective contribution, we'd be a much poorer state. There's no question about that. So thank you all very much. We'll now move to our next witness. We've gone a little bit over, so it'll be a quick transition to our next witness. Great. Well, we'll welcome now our next witness to the inquiry, Dr. Ruth Arnold, OAM, and we welcome you very much to this inquiry, public inquiry today, Doctor, and we're looking very much forward to hearing from you. I'll need to deal with the formality first of having you either sworn or affirmed to give your evidence. So what I'll ask you to do, if you could please, is to state your name, your position title upon which you're appearing before the committee today, and swear either an oath or an affirmation, whichever you prefer. The choice of the words should be presented to you. So I'll invite you to do that.
Thank you very much for the invitation. My name is Dr. Ruth Arnold. I am the Rural Co-Chair of the Medical Staff Executive Council of New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much, Dr. Arnold. Can I just confirm that with respect to the submission from the New South Wales Medical Staff Executive Council, that there's very helpful submission, and I presume you've had some involvement in its development, if not a significant amount of involvement, has been received by the committee. It stands as submission number 276. It's been received, processed, and stands as evidence to the Commission. So we thank you and the Executive Council very much for that. You can take it as read. All the committee members have a copy and will have read it, and no doubt we'll have some questions for you. Can I commence by inviting you to make an opening statement, and if you're agreeable, we'll then move to questions and we'll share it between the committee members to take us through the duration of your time this morning.
Thank you. So firstly, the opening statement by way of introduction. The New South Wales Medical Staff Executive Council is formed as the Medical Staff Council chairs of all New South Wales public hospitals. These are the elected representatives of all senior medical staff employed at public hospitals. Input for this inquiry has been provided from senior doctors across New South Wales with decades of experience within the public hospital system. It is a sincere hope of the New South Wales MSEC that the current parliamentary inquiry will be able to synthesise all the material it receives and make robust recommendations for comprehensive bipartisan reforms of key areas of the New South Wales healthcare system. Providing equitable access to high-quality healthcare for regional and rural patients requires a fundamental change in philosophy in how New South Wales chooses to structure and deliver healthcare services. That requires a change to the current structures to create a truly statewide model aimed at ensuring equity of access and uniformity of healthcare standards. The problems that exist in the delivery of regional and rural healthcare have been well documented. The fact that there are problems with staffing, resourcing and health outcomes is well established. Follow-through of effective coordinated reforms have been deficient to date. Improvements can be achieved when large, ambitious clinical improvement programs are funded and coordinated at a statewide level, such as the Rural Cardiac Catheter Lab and Reperfusion Strategy between New South Wales Ambulance and Health. Big gains can be improved, so it can be done. However, statewide focus needs to be applied to many other areas. So, in essence, the keys to making a big difference in rural healthcare delivery need to focus on delivering key structural reforms in 10 key areas, which I'll summarise briefly. Re-establishment of statewide services planning rather than a reliance on the current silo LHD model. In general, rural hubs for almost all services can and should be established, as a metro-centric model is not cost-effective. Highly intensive subspecialised services need robust services to ensure equity of access, such as paediatric intensive care. Number 2, reform the independent oversight and governance structures. The Auditor General report covered this and made recommendations in 2019. Number 3, establish avenues for early conflict resolution which are independent of the LHDs, in particular in cases where a medical staff council votes no confidence in a hospital and or LHD administration. An automatic and comprehensive review independent of that LAD must take place by external agencies. Number 4, review the role and performance of the LHD boards. These were intended as an oversight body distanced from the CE. This has not always been the case. The Auditor General noted a lack of clarity on what is operational and what is strategic, and noted a need for formal board orientation and education. And some boards see themselves as rubber stampers, which may reflect the reality and the deficiency of the current LH boards as strategic oversight bodies. Number 5, fix the poor engagement of boards with clinicians and poor inclusion of clinicians in decision making, and set KPIs around that. Number 6, stop the overspending of public money on consultant reports, which was $29 million in 2020, and reinvest this money by consulting clinicians within the organisation or within the pillars that could build resources and strategic planning in-house. 7, take the huge wealth of data that we are currently generating and use it to improve systems. 8, address the specialist workforce distribution at a statewide level. The myth that current deficits in per capita specialists in regional and rural areas due to specialists not wanting to go rural must be dispelled. It should be understood that obtaining approval to fund a new position can take years of business cases and lobbying, and leaving workforce decisions solely in the hands of LHD finances is a poor system that doesn't take a statewide vision on workforce distribution. 9, ensure stable referral pathways for the transfer of regional and rural patients to hub and metro hospitals and establish KPIs on waiting times. And 10, ensure that any rural health solutions for telehealth meet short, medium and long-term needs of regional and rural patients, and that they support and communicate with locally based clinicians and do not seek to replace them. So that's a summary of where we find the key areas and the way forward, but I'm more than happy to take any questions about any content of our submissions or any of the areas where we think reform is key.
Thank you, Doctor. And before we commence, can I just acknowledge the enormous contribution that you've made in your own right, noting that you commenced as a cardiologist in Orange in 2001, which is 20 years ago. And you bring such knowledge, experience and insights forward to enable us to ask you questions. And we'd just like to thank you very much in making your time available from what is obviously a very busy schedule. Can I commence with the Honourable Walt Secord?
Thank you, Mr. Chair. Thank you, Dr. Arnold. Can I go to one of your recommendations where you talk about early conflict resolution? Now, we've had evidence to this inquiry that doctors who see faults or problems in the health system in rural and regional areas fear retribution from New South Wales Health and the government. Do you, as rural co-chair of the Medical Staff Executive Council, do you get reports of people wanting to make recommendations or highlight deficiencies who are fearful of retribution from New South Wales Health?
Look, absolutely, the current system doesn't make this easy when people need to raise concerns. So the problems are that there is a tendency for staff to raise concerns, administrators to defend their position because they don't want to admit that they're wrong or that there's blame. And that situation needs to be diffused so that the focus can be on patient care and on quality and on sifting through what are genuine concerns about how the system's running, and getting away from the self-defending stance of some administrators. And then you have processes whereby New South Wales Health doesn't always have the jurisdiction in the current model, nor the resources to look into everything in as much detail as they could and should. And they rely on the inputs from the LHD. They ask the LHD, well, what's all this about? The LHD can tell New South Wales Health what they like and that everything's okay, which is not always the case. And the resources to independently step in and arbitrate are deficient and lacking. And sometimes that can escalate to horrible degrees. There have been cases where local health districts have had clinicians trying to raise concerns about, you know, deaths that should not have occurred, that haven't been reported to the coroner, that about major systemic problems such as in Broken Hill. And it took a long time for those doctors to manage to get anywhere, to get any traction outside of their LHD to have those concerns investigated. And there was a report done and multiple recommendations made, and yet the local health district that had overseen some of the problems in the first place was then charged with the implementation of these reform. So this is a system that doesn't work well on behalf of patients or concerned clinicians within the organisation. There needs to be a better, less adversarial way to fix it. So I would recommend that, the Garling pillars were meant to have more resources than they have. They were meant to be able to perform some of this role. I was on the panel to oversee the Garling recommendations, and the implementation of those left out key facets. Leaving out key facets of a recipe is like cooking a cake without the baking powder. It's going to be a flop, okay? So if you don't have the correct audit structures and the correct accountability, you create these problems. So yes, staff do retribution, and it's a problem.
Do you find that, in fact, rather than concentrating on fixing the problem or improving healthcare, that there is more an interest in defending the situation or refuting the doctor making the allegation than actually trying to fix the problem?
Absolutely. Absolutely. There's a defensive stance, there's a cover-up mentality, there's a keep things out of the media at all costs. But there's some fantastic people in New South Wales Health who, when they do step in with sufficient resources, can analyse and sort through what's true, what's not. But there needs to be avenues where people who can give proper input to these very serious situations can do so in a more timely way. The doctors and nurses who raise concerns about their patients and about the patient care and about administrators who, in some cases, are simply not even following mandated New South Wales health policies and procedures. They shouldn't have to go through the hard processes that it takes to raise these concerns. There should be given standards of administrators' performance, and if they're suboptimally performing, there should be not a defence of their actions at all costs. There should be a genuine analysis and a way of fixing that. I think the problem becomes if there's an admission of guilt, there's a number of facets. Often if you admit guilt, apologise for something, analyse it and fix it and move on, which is what we're used to doing as clinicians. If healthcare isn't optimal in every case, that's what we do all the time. But we need to take that approach to take the heat out of the problems when there's an administrative issue. You need to be able to say, oh, okay, that wasn't right. We can do better. This is our plan moving forward. So take the adversarial nature out of it.
Now, Dr. Arnold, we've heard repeatedly across the state that there are emergency departments in rural hospitals where nurses end up being the only line of healthcare in those hospitals, and doctors do not want to work in those emergency departments. Now, we want to make tangible recommendations. How do we get doctors in emergency departments in these rural and regional areas? What's the barrier, or what's the barrier to this occurring?
So there are many facets and different solutions for different locations. So there are different levels of hospital. So there are certain levels of hospital which I believe you have to staff, and there are some whereby you can utilise healthcare resources wisely and still provide a service. Let's just take a look, for instance, using the vast area of Western New South Wales Local Health District as an example. If you have no doctor in a remote facility, but you have a nurse, you can manage even very unstable patients if you have to with phone backup, with ambulance service backup. There's a program called SIRS Assist, whereby paramedics can come into the healthcare facility to assist nursing staff to stable a patient for immediate transfer. You can have critical care experienced doctors and emergency physicians and cardiologists on the phone, even via video link, to assist that process. Is it better if doctors can be obtained to staff all of these areas? Yes, but if that's not available, I think you need to look at, are the resources of nursing staffing adequate, and are the resources of paramedics and ambulance staffing adequate to all of these areas? Because these are valuable avenues where there are more staff easily able to be obtained, who can make a massive difference to patient care and deliver a quality service. In terms of doctors, sometimes the very small sites can struggle to find permanent workforce. There needs to be a focus on supporting and making those jobs attractive so that there are a permanent workforce in those areas to follow through and provide long-term care for patients. You won't always be able to staff emergency departments with local people because no doctor can do one on call or even 1 in 2. It's not rational. So you need a support structure that utilises all healthcare professionals in your model.
Now, Dr. Ruth, we've had evidence of doctors working extraordinary hours per week, between 60 to 90 hours a week. Now, are those doctors in rural areas, are those just outliers, or is that something that you hear quite commonly, that doctors are working extraordinary hours in rural and regional areas?
60 to 90 hours. So that's 5 12-hour days. Yeah, that's pretty normal. Yeah.
That's normal.
It's rural and regional doctors have an enormous demand for services that would not be uncommon at all. 40-hour week in medicine rural doesn't exist.
Doesn't exist. Now, you've been in Orange now, I'm saying, some 20 years. During that time, do you provide cardiac advice to nurses in remote and regional hospitals? Do you use telehealth? Absolutely.
We run a centralised STEMI service in Western New South Wales, LHD, which covers a vast area of the entire state. It's an enormously successful program that has improved the health outcomes considerably. We've run that 24/7 service since about 2013 or 14. So we support paramedics in the field with direct phone calls to paramedics who are caring for patients having heart attacks in the back of ambulances. We support nurses who've got no on-site backup in small hospitals. The key to the system is a networked approach, and it feeds into respectfully combined with the care provided in each of those settings by all healthcare professionals and doctors, and it is a system that feeds back into follow-up locally. It is an excellent telehealth model. So telehealth can be extremely useful, powerful tool, but it needs to be very carefully constructed.
I understand that. Now, do you have situations with we've had reports of the use of telehealth? Are there certain areas where you think that telehealth should be a no-go area? Are there certain things that it's just impossible to replace a doctor with?
Yes. So the cardiac services is the heart attack support program. That's one component that works well. Second component of telehealth, Western New South Wales LHD has run originally a service called the Critical Care Advisory Service, and then moved to V-Care, virtual care, and there were massive problems with the rollout of that particular model, and numerous feedback of poor systems from specialists that were involved with the change. Now, the keys and the differences in the change is that in the first instance, it was run by locally based consultants with skills in critical care or emergency medicine. So they were, at a high level, they were locally based, so they had a fundamental respect and knowledge for the other clinicians working with the area, and a knowledge of the towns and the people and the system and the infrastructure and the resources that they were dealing with. You then had a shift to a model under the directorship of somebody not from the area, often employing people not from the area, and that program is still under in the process of being improved, because of the fundamental problems were that there was if you put someone on those lines who only deal with the here and now for the patient, who don't focus on their medium and long-term needs for healthcare follow-up and don't plug back into the local system and don't have an understanding of the local system and what's available, it's a disaster potentially for patients. And secondly, the staffing experience and the level of people who were then put on to that service were variable, and some of them were just simply not of an adequate medical standard.
Well, what do you mean?
Thank you very much. Thank you, Darren. We'll need to move on, and we may have time if we do at the end to come back. Can we now move to the question from the crossbench? Deputy Chair, Honourable Member Hurst.
Thank you, Chair, and thank you, Ms Arnold, for coming in today. One of your key areas that you highlighted in your opening statement was around poor engagement from boards with clinicians. And I wanted to know a little bit more information about what was actually happening here on the ground. What are the outcomes of that poor engagement, and what does change actually look like as far as a recommendation within the inquiry?
Yes, medical engagement with senior doctors and nurses in healthcare services is crucial to a team approach and building a robust service. The boards are supposed to routinely engage with the chairs and medical staff councils and routinely invite them to every meeting. That doesn't always happen, and due to the current system, where even if the medical staff council chair attends, their role in board meetings is limited, their input into and ability to influence key service delivery decisions is profoundly limited. There's no defined structural role about what input the medical staff do have, could have, should have in the structure. So often there's not a lot of point them turning up because they feel that they're barely involved if they do. So there's a disengagement with that entire process. The Auditor General report acknowledged that the input into local decision making hadn't been realised in this devolved model as well. So it's well recognised it's not functional. There was surveys across the state of all the MSC chairs that we conducted and is on our website, which demonstrated, you know, that many MSC chairs are never consulted and never invited and don't have any quality input. Look, it is a deficiency of the system because the key people who know what needs to be improved on the ground are your senior doctors and nurses. So I think that the system, what does it look like to reform it? I think routine inviting senior doctors and nurses to board meetings, but actually giving them a voting role in service delivery and models of care so that it's worthwhile their input and their time investment in attending.
Yeah, thank you. Thank you for that. I just wanted to also talk about a couple of things that you mentioned specifically in the submission. You note in the submission that the KPIs for LHD are mostly about volume or time frame based or focused on financial measures. But in order to improve those clinical outcomes, the KPIs should be clinically based. Can you tell us a little bit more about that and just sort of expand it for the benefit of the committee?
Yeah, so there's a big focus, for instance, on emergency access times. Now that's important because if people go to an emergency department, they want to be processed quickly. But processed is a word, you know. Are they processed and shuffled into a corner somewhere just to meet those targets, box ticked, but, you know, without a thorough medical assessment that met their needs? Well, it's hard to capture that. You can capture that in terms of, you know, readmission rates to hospital and things like that, but we already collect a wealth of data. The Bureau of Health Information collects a lot of data on outcomes of clinical conditions, key outcomes like 30-day mortality for heart attack, stroke care, outcomes for people who break their hip and how the systems are performing. And that data gets published and put on a website. It's usually only every 3 years, but there's no real-time fix. There's no, you know, focus on that clinical data about how well a hospital system's treating heart attacks, hip fractures or whatever, and putting a KPI around that and saying to the board, well, you know, you haven't dealt with this very well. Your figures are as bad as they were 3 years ago, and having any financial repercussions or key inputs requiring them to recommend to implement best practice to improve those figures. So the focus is on time, emergency access, and off stretcher times, which is only one part of the equation. It's not how good is the quality of the service you're running, and it's also not looking at other facets of the problem, such as, you know, there's a lot of bed days in hospitals that are spent wasted money of patients waiting for transfer to another hospital for definitive care or waiting to get back again. If there's no KPI around that, then your hospital system gets clogged up with poor patients who are waiting for care that you're not measuring, that there's no KPI around it because you're only focusing on getting people off ambulance stretchers. So if you don't look at the whole system in your analysis, then I think you come up short in looking at where the problems lie and keeping the flow going right through the system in an economical way.
And just on that point about, you know, transferring patients, I think you also said in your submission that the model of transferring regional and rural patients to metropolitan centres is more costly than actually investing in local care. Can you talk a little bit more about that and that sort of costing?
Absolutely. So New South Wales Health spends about, I think it's about 112 million per annum on transfer. You won't be able to save all of that, but you can save a lot of it. For instance, the rural catheter lab program is one that I'm very familiar with. Now, prior to that program being rolled out under the former statewide services, which of course no longer exists, that program has shifted care of heart attack patients in the regions, remaining in the regions. So Western deals with you know, at least 80% of its heart attack work and does all of the stents and the care that's required without transferring them to Sydney. Now, prior to having a cath lab in 2012, all of that work went to Sydney. So, you know, that's about 400 patients a year, so 80% of whom are kept in area. Without that, you know, that's, you know, 400 times $5,000 an ambulance ride at least. So that's quite a lot of money to invest in local services, local infrastructure and local jobs. So these are cost shifts that not only benefit patients and give much better value care, they're cheaper, more effective, and they give local jobs for regional and rural nurses, radiographers. It builds skills, and it's a better investment for the future of New South Wales, because you're spending more money on actual healthcare and less on transport and aircraft fuel. More money on patients.
Thank you very much. Dr. Arnold, can I confirm that you would be, if you're able to do so, be available for an extra 10 minutes till 12:15?
Yes, certainly.
That's wonderful. Thank you very much. We'll move then to Kate Femming.
Thank you, Chair. Thank you, Dr. Arnold. I just wanted to go to your excellent submission, which we've got a terms of reference where we have to look at the analysis of the planning systems and projections that are used by New South Wales Health in determining the provisions of health services. So you've talked about the fact that the statewide services section of New South Wales Health was disbanded when the LHD system was set up, and that as a result of that, there is no department within the New South Wales Ministry of Health with the expertise or the brief to address the long-term issues of poor access to medical care across the state in terms of rural and regional services. So that's quite extraordinary. So there's nobody, there's no specialty or no department within New South Wales Health to address that. Is that correct? And it's just happening within each LHD?
Correct. So, and this is a big problem. Now, as I said to you, the Garling recommendations were rolled out with some key facets missing, and that creates, you know, the cake that's a flop. The Agency of Clinical Innovation was envisaged to be the body that would define what is best practice care, what are new innovations in healthcare, and what the standards should be across the entire state. Now, the Agency of Clinical Innovation has some fantastic people in it, but it's under-resourced. You see, it was meant to come with the resources of access, ready access to people with skills in business cases, cost analysis, people with skills in change management to roll out programs across the state. So these resources were never made available to the ACI. Therefore, it hasn't really ever been able to take on the role that the former statewide services under Kathy Misleading had in establishing, well, where are the services needed? So you need hub services for cancer care in these locations. You know, here they are, here are the resources to match, and here's the change management that goes with that, that tells the local administrator, this is what you're doing, this is what looks like best practice, and this is how it's going to be run. So the ACI could and should be the pillar that is tasked with this, but it has to have the extra ingredients and resources available to it to do so. And that money could easily come out of the $29 million that's currently spent per annum on often useless reports from external consultancies. That's a lot of money that could be invested into this strategic role within the pillars. So, you know, there's a lot more that can be done in this space.
Do you also have a view then about the amount of funding that has been put into new hospitals in some regional centres then compared to, for example, the lack of resources into the ACI?
So the rural hospitals have been terribly under-resourced in terms of infrastructure and running costs. So sometimes that investment in rural infrastructure has been necessary. But the infrastructure is one thing. You know, there's been cases whereby the infrastructure has been present, but the commissioning of it and the ability to staff and run it has lagged a number of years behind the provision of the infrastructure. The opening of the Wagga Cardiac Cath Lab would be one example. So, and even, you know, once again, I guess I keep using the cardiac examples because I know them best, but the infrastructure exists in those key locations ready to serve patients. However, most of the rural cath labs are not resourced or permitted to run 24/7. So you've got patients who've got a cath lab in their local health district, but it doesn't run after hours, so they're still transferred out of area. Well, that's just not good for patient care. But the resourcing to say to those cath labs, you know what, the facility is here, you need to run it and treat patients 24/7. That decision rests with the LHDs. It's not a state-based decision that says, you know, every patient should have access to 24/7, you know, heart attack care. It's left to the LHDs about how they run and resource that. To get the Orange Cath Lab open 24/7 took us, you know, years of business cases and banging our head against a brick wall. It takes sometimes a massive amount of effort from the clinicians on the ground to keep persisting and advocating on behalf of their patients and their communities to get these services to a level where they should be. And sometimes the business cases, it's there, you know, you don't have the resources yourself to do the business cases, and that should indeed be provided from people with the appropriate management skills. And the local health districts in regional and rural areas don't always have resources of experienced managers. You know, we've had numerous managers through Orange of varying experience, and some of them with no health experience. So you kind of have to reinvent the wheel each time the business managers change. And there simply should be a better statewide system that says this is what's cost effective, this is best care, and this is what we're doing.
Thank you, Jeff. I can just have one last quick question.
Okay.
So this is due, I think, again to what you have got in your submission, but because the LHDs are meeting KPIs that are all kind of budgetary and are operating under budgetary constraints. So therefore, for example, a 24/7 cath lab, they just look at it in terms of the fact that they have to meet KPIs around budget rather than demand. Is that what's going on in regional New South Wales?
Yes, they see a tight budget, but this is why I said some of these budget decisions need to be at a statewide level, because you see that they focus on their budget, okay? So by not running that service 24/7, there's huge extra money, you know, say 400 times 5,000, what, 2 million in additional costs to transportation of those patients and to caring for them in other locations, not to mention the cost to the patients and their families that's travelling out of area. So that cost isn't on the LHD budget, so they don't necessarily care about that. If you're looking at a statewide spending and the whole of the taxpayers' dollars, well, that makes no sense, okay? So sometimes the small amount of investment, you could run a whole lot of cardiac catheter services for, you know, the cost savings in the transport costs. And those are the arguments that sometimes get over the line, but if it's not on the same balance sheet, then they don't always go for those fairly obvious solutions when you're looking at money that's coming out of a statewide budget.
Thank you. Thank you very much, Dr. Arnold. The Honourable Wes Fang.
Thank you, Chair, and apologies for the lighting. It's the sun, it's not a halo. I just wanted to touch on the telehealth services that have been raised already during this inquiry. And what we've found is that there's been a lot of demonisation of telehealth and a lot of political games, I'll say. But we were supposed to be in Wagga today, and part of the reason that I was very keen for this inquiry to go to Wagga is to have a look at things like the telestroke program, where if there is a patient having a stroke in a rural regional area, they can get that advice from stroke specialists, and the outcomes have been very good. Are you able to provide some positive feedback on how telehealth has provided some positive outcomes for patients in rural and regional communities?
Absolutely. As I said, the telehealth cardiac program, which helps to treat heart attacks by beaming ECGs and connecting key people caring for patients with consultant cardiologists and emergency physicians. That networked approach is powerful and makes an enormous difference to improving outcomes. The telehealth program for stroke is also an enormously powerful tool whereby you can have a video link set up and have an expert brought to the bedside. These are all powerful tools and excellent programs that can achieve big gains. But where those programs, they link with local clinicians. They don't replace them. They're bringing a specialist to the bedside. So they're bringing specialist care over the top of basic healthcare services. So you've still got doctors and nurses and paramedics caring for those patients. You're bringing additional assistance to those clinicians in helping them care for patients. So where telehealth can be quite rightly criticised is you cannot replace always a hands-on approach, and there's certain things telehealth can't do. And telehealth must link with local clinicians. It's got to provide structure for ongoing care and ongoing assessment. And I think where it's fallen down and can be rightly criticised is when assessments are poor, where, you know, the consultants giving the advice may not have had adequate experience or adequate ability to assess the information, where instances where there hasn't been arrangements for follow-up. There's been some terrible examples of mistakes made in, you know, cardiac care with patients sent home with inadequate assessments and no follow-up arrangements. that we've had to pick up within our area because we monitor it and watch it to a degree, because we have the ECG service. So if we can see an ECG that has not been dealt with appropriately, we've got some avenue, but not routine checking steps to say, is that service fit for purpose? Is it performing well? So telehealth, amazingly powerful, fantastic tool that can bring a specialist into a patient's bedside and use technology to its best advantage, but in a role and a model that supports clinicians on the ground and that provides a whole of patient care model into the future. That's where it's key. I think a sloppy service where someone, you know, wants to sit on a beach somewhere and you know, provide ad hoc advice without a connection and an understanding of a rural location is a poor model. And depending on their level of expertise and whether the presence of that service blocks recruitment of on-the-ground clinical staff, that's where I think you have to juggle the model and make it what it needs to be, which is bringing additional resources to the patient.
Do you agree, though, that in demonising the word telehealth, what perhaps we are doing is losing the ability to give confidence to patients that perhaps are in rural and regional areas that may be, for example, experiencing a stroke or a cardiac situation, that a clinician or a senior nurse in a, say, an NPS or a rural hospital may say, you know, I'm going to get the telehealth doctor on as an indication that they are going to connect to the telestroke or a cardiac service. And all of a sudden they hear the word telehealth and the patient has, I guess, a concern because of the negative connotations which have been progressed by people with political motives. Does that create an issue for us? Do you think we should be very careful about how it is that we talk about telehealth and not lose the benefits that we can get from the service by trying to politicise the issue?
So I think a patient that experiences a well-performing healthcare model doesn't usually have a problem with the delivery of that model. I've certainly not come across patients who've had sort of problems with the involvement of clinicians via video or telehealth link. But I guess in our model, then those patients are almost always seen by the clinicians involved as part of their episode of care. So it's a tool that allows the outreach to them quicker, but then they still see a doctor. So I think that without wanting to, you need to make telehealth services excellent, and then any bad reputation around them will be diminished. So they have to feed into on-the-ground services. You cannot replace with video the examination of a patient. Even in conducting in COVID, we've done a lot more telehealth, and there are some things that you can do via a telephone, some that you can do via video, but some that at the end of the day you have to do in person. So you can only stave off even seeing relatively stable patients for so long until somebody, be it doctor or nurse or clinician, must examine them properly, because you can't pick up all things on a video link. Things get missed. So powerful. It has to be structured well, and that's still work in progress. I think a lot of these technologies are relatively new, and their power and their role in medicine is still being defined. But definitely don't throw the baby out with the bathwater, because telehealth, as I said, powerful way to make a massive difference in some conditions and to bring specialist care into regional rural areas more comprehensively and at an earlier level, which can make a big difference.
Well, look, thank you very much for your insight I know my time has pretty much expired, but I really do value the experience you've brought and what you've been able to provide via testimony today. And thank you very much for providing some balance to the telehealth system.
Thank you.
Mr. Chair, I understand there's about 30 seconds left. Can I just clarify something that the Honourable Wes Fang has said? The evidence that we had concerns about telehealth came from nurses on the front line rather than patients. So I just wanted to correct that. That was nurses that expressed concern about telehealth. Thank you.
Okay, I'll take that as a comment, I suppose. So listen, well,
I was going to say, yeah, we could raise a point of order that, really it should be a question directed to a witness, but, by all means, the Honourable Walter Secord is very good at making non-compliant contributions to the debate.
Thank you. He probably would say to that he's learnt from the master, so we'll leave that there for the moment. Dr. Arnold, on behalf of the committee, can I thank you very much for making your time available today. We know that you're exceedingly busy, but can we thank you for your tireless work, the research that you undertake, and the very forthright and strong advocacy that you bring to the discussions around what we all want to do. And I don't think there's any question around the committee table. It doesn't matter what party we're from. We all want to see what might be the ways and means that we can, as a state, raise and improve the health and the well-being of the citizens who live outside the big and the large metropolitan areas. So thank you all very much. So that brings us to the conclusion of the hearing. We now have a break until our next session, which will be after the lunch, which will be recommencing at 1:25 p.m. I don't know whether Vanessa or Sharon, you had any comments you want to make before we break for lunch? Well, listen, we may get proceedings underway. I expect that the Honourable Wes Fang will join us shortly. But we've got much to get through this afternoon, so we ought, as far as we can, stay onto our timelines.
Apologies, Chair. So I just was otherwise involved.
No, that's all right. No worries. No worries. So welcome the Honourable Wes Fang. So we're just about to get underway, and we welcome our first witnesses for this afternoon. Thank you very much for joining us, Associate Professor Malouf and Ms. Cashman. What I'll do, if I could please, is do the formalities first, which is a requirement of the public hearing, to get each of you, starting with Associate Professor, to state your name, your position title, and swear either an oath or an affirmation, whichever you prefer, and you should have been provided with the words of either one which you've selected. If for some reason those words not been provided, just please let us know. So we'll start with Associate Professor Malouf.
Thank you, Chair. So Associate Professor Peter Malouf, Executive Director of Operations for the Aboriginal Health and Medical Research Council. I'll provide an affirmation. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth and the whole truth and nothing but the truth.
Thanks very much, Associate Professor. That's great. Can we now move to Ms. Cashman? Could you please follow the same procedure of name, position, title, and then either an oath or of affirmation?
Thank you, Chair. My name is Margaret Cashman. I'm the Director of Ethics Policy and Research at the AHNMRC. I will do an affirmation. So I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. Thank you.
Thank you very much. And on behalf of the committee, can I thank you both very much for making yourself available this afternoon. We know you're very busy with your various commitments, and it's a privilege to have you both this afternoon, being able to provide us with some public inquiry. Can I confirm that with respect to the submission that's been made, the submission's been forwarded, as you would be aware, to the committee secretary. It's been processed, and the submission stands as submission number 265 to this inquiry, been processed, uploaded onto the webpage of the inquiry, and obviously is there for people to study. That is obviously evidence, which is very, very helpful for our inquiry, but we've now the public hearing part of it and the opportunity to hear from you in person, which is very, very fortunate. What we normally do is, and hopefully this is agreeable to you both, is that we'll ask for an opening statement from one or both of you. I'm not quite sure how you've decided to do that, but one or both. And then we'll move over to questions from committee members, which will then allocate across the three groups, the opposition, crossbench and government, to take us through to approximately 10 minutes past 2 or thereabouts. So is that procedure agreeable to you both?
Yes, Chair.
Thank you very much. That's wonderful. So, Associate Professor, can I invite you to take the lead? Were you going to make the opening statement on behalf of both of you, or are you going to share it?
That's correct. That's correct, Chair. I'll make it. Great, thank you. Look, thanks, committee. I firstly just like to acknowledge the traditional custodians on whose land we meet upon today and pay respect to elders past, present and emerging who care for and continue to care for country. We also acknowledge non-Aboriginal people who are present here today. We thank the committee for allowing us to speak with you today. The Aboriginal Health and Medical Research Council for New South Wales is a peak organisation representing 47 Aboriginal community-controlled health services in New South Wales. Our primary focus is advocating for health equity while supporting our members in delivering high-quality, comprehensive primary health care for Aboriginal individuals, families and communities. And we are pleased to have provided a submission to the committee, and we're happy to discuss today, which talks about some of the critical challenges faced by Aboriginal people accessing health and hospital services in rural, regional and remote New South Wales, but also the work our Aboriginal community-controlled health services do in supporting culturally appropriate access to support physical and mental health. In essence, our submission, we call for an integrated and culturally appropriate healthcare service or system for over 165,000 Aboriginal people living in regional, rural and remote New South Wales. The system must be supported by formalised and genuine partnerships between local health districts and Aboriginal community-controlled health services. We know that this fragmented partnership impacts the quality care given to Aboriginal people and contributes to Aboriginal people presenting at hospital services or health services at the later end of disease progression. And sadly, Aboriginal communities in rural and remote settings are losing family members to suicide, and many Aboriginal people in New South Wales often do not feel culturally safe when accessing health services. In rural and remote regional settings, mental health services have little knowledge on or understanding of Aboriginal culture and history, and therefore Aboriginal people are often reluctant to seek help for mental health services. We know that better care given in community will optimise better health outcomes needed for Aboriginal people. And we know that our 47 Aboriginal community-controlled health services do recommend that the New South Wales health system needs large-scale reform to improve Aboriginal people's health and wellbeing in New South Wales and generally, but more particularly in regional, rural and remote areas. So thank you, Chair.
Thank you very much, Associate Professor. That's a very precise and clear opening statement, which I think sets us up very nicely for questioning from committee members. So you're okay that we proceed now with the questioning?
Yes.
Thank you very much. So we'll get things underway, and can I invite the Honourable Watt Secord to commence the questioning?
Thank you, Mr. Chair. My first question will actually be to both participants. So in your submission, you talk about Aboriginal people having a higher level of disengagement from the hospital health system. What do you mean by this, and how do we, in fact, overcome this?
Sure. So what we mean by this high level of disengagement to the health system is that we know that historical factors impact on Aboriginal people accessing Western or traditional healthcare services. We know that particularly in rural remote communities, Aboriginal people have fear factor of going into the health system because they've seen many Aboriginal loved ones and community members going through to hospital and then ending through passing away. And so there's this level of fear factor when they enter the hospital system that they may come out deceased at the end. And so there's this reluctancy of going in to tertiary hospitals. And I guess what we were wanting to see and wanting to talk about is about improving cultural-based care. So that's about how do we make hospital systems more culturally appropriate and friendly for Aboriginal people to enter into the system, but also afterwards. And I think we appreciate that Aboriginal community-controlled health services play a vital part in providing that cultural support that's needed.
Well, when you, sorry, Ms. Cashman, would you like to add to that?
The only thing I would probably add is really around the feedback from our member services, which also speaks to the disengagement, is when people are presenting to the ARCHOs with a preference to try to receive care from the ARCHOs that they will need to receive in the hospital. So we know that that does happen. They are asking to be treated by the ARCHO primarily because that is where they feel safe. So that's probably all from me.
Now, I don't know if you were watching evidence earlier today, but we received evidence involving cancer treatment in rural and regional areas, and CanAssist and the Cancer Council of New South Wales said that, in fact, if you live in Sydney, that you would receive world-class treatment for cancer treatment. However, if you lived in a rural and regional area, that many patients would be skipping treatment because they could only access privatized services and due to remoteness and unable to, in fact, be able to financially access those services. So it must be exponentially more difficult for First Nation people in New South Wales to access cancer treatment. Do you have a view or an observation on that?
Look, we are working closely with the Cancer Institute around understanding the nuances around the prevalence of cancer, particularly in rural and remote communities. And we certainly are seeing there are a high number of prevalence of Aboriginal people diagnosed with cancer in those settings. And yes, we are hearing from our member services that the only course of treatment is in metropolitan New South Wales. And so we want to obviously understand within the health system, what are the capacity building, what resourcing is going to be added for regional or remote communities, because we know that if you add those tertiary services in regional or remote communities, you're optimizing better health outcomes, particularly for Aboriginal people, because they're being treated on country, they're not being removed or dislocated into metropolitan Sydney for treatment. So yeah.
Ms. Cashman, do you have anything to add to that?
I think Peter summed it up nicely, but probably just to say we are seeing some of our member services applying for grants to be able to facilitate that travel into Sydney to improve the timeliness of diagnostic services, improve the access to cancer care services. So there really is a need to build that capacity in the regions, as Peter said, definitely.
Now, you both probably are aware by listening to me that I have an accent. I was born in Canada, and I know that First Nations people in Canada have a reluctance to go to hospitals because, unfortunately, in First Nations communities, you only go to hospital when you are really, really sick. And if you're really, really sick when you access health services, then you're going to have bad outcomes, which means deaths in hospitals. So how can we make recommendations so that services in rural and regional areas will be more culturally sensitive? I'm not talking about there's a proposal from the AMA where they wanted to put up Indigenous paintings in emergency departments. I think you want to go beyond that. So what are there some tangible recommendations that we could do to make services more culturally sensitive?
Yeah, so I guess what we want to see is formalize and genuine partnerships with our Aboriginal community-controlled health services in those rural, remote and regional communities, because we have services that are in those settings that can offer the cultural support that's required for Aboriginal people, but also can support and navigate Aboriginal patients through to the hospital system. What we're seeing at the moment is that there's this disconnect of patient journey through. So when an Aboriginal patient rocks up to a hospital setting, and with not giving information to the ARCHOs, they get caught unaware that their Aboriginal patient is being presented at the hospital and then discharged as well, so transitioning out. So Aboriginal community controlled health services is not a part of the discharge planning process. And so what we want to see is that in this formalised partnership, there's this better working relationship with the ARCHOs in those communities, so we can better streamline the patient journey, so it's not just fragmented at the moment.
Now, we hear this phrase all the time, and I was Shadow Health for 5 years, and on this committee for greater part of a year in health committees. And we always talk about integrated care. Now, can you turn that into language that's layman's language? What is integrated care that you're calling for?
Yes, when we talk about integrated care, is that we want both, basic primary health care, as well as hospital, all working together, right? So when a patient, is diagnosed and needs further treatment in the hospital setting, that the care of that patient is supported by both primary care as well as tertiary care. And so that's that integrated component, right? Because at the moment, what we see is that we see patients tend to fall through the gap when there isn't a seamless pathway, health pathway for an individual. And so, the reason why there is a gap is that there's no standard practice around sharing information of the patient's journey, right? So what we want to see is that our Aboriginal community controlled health services are the point of care for our patients, but at the same time are receiving timely information of their care when they are presented into hospital, but also on discharge, so that again, it supports that patient journey and that seamless approach for an integrated model.
Do you find that in remote areas of New South Wales that medical practitioners are being forced to resort to telemedicine? And with telemedicine, are there implications and difficulties for First Nations patients?
Well, look, I guess in terms of, if we take the COVID situation, certainly telehealth has amplified the use of that particular technology. But, what I guess Aboriginal patients require is that face-to-face interaction. And the telehealth has created a barrier for mob in terms of their care management and compliance. And so, Aboriginal community controlled health services do utilise telehealth, but they also have the second component of that face-to-face interaction. So, if a patient, is homesick and they can utilise the telehealth function, but then our services also provide the welfare check. So they actually go to the home to check on the individual on how they're travelling. Look, telehealth and face-to-face need to be working hand in hand, particularly in Aboriginal health.
Okay, I'm mindful of time. I'll ask one more question. Now, we have challenges involving palliative care in rural and regional areas, but it must be extraordinarily difficult to provide culturally sensitive palliative care in Indigenous communities to First Nation peoples. What are the challenges and what can be done in that area?
Oh, look, it's about, we know that palliative care services, particularly in regional or remote communities, are very scarce and limited. And so, if they are needing to go to, Sydney for further treatment, giving Aboriginal people the option to go and die on country is important. So it's about acknowledging cultural protocols and practices in terms of, their end-of-life journey and for the system to support those cultural practices. The system needs to understand and appreciate that the patient has a right to decide on where they would like to end, their end of life, and which is majority of our Aboriginal communities want to be back on home, back on country.
Now, the challenge of COVID must be sort of magnifying the difficulties of treatment for Indigenous people in Western New South Wales, particularly. How's that working itself out involving health services?
Oh, look, I guess we're fortunate enough to have a number of Aboriginal community-controlled health services in Western New South Wales that are working together on providing better health outcomes for their Aboriginal communities, and they share resources, they share staff to support the current situation that's Western New South Wales find themselves in. But what we want to see is better support from New South Wales Health, particularly in Western New South Wales, to support that collective effort and also provide further resourcing for our Aboriginal community-controlled health services in Western New South Wales.
Thank you. Mr. Chair.
Thank you very much, the Honourable Secord. We now move over to crossbench members. Deputy Chair, the Honourable Emma Hurst.
Thank you, Chair, and thank you both for coming here today. I'm just going to ask a couple of questions in regards to your submission. The submission actually says that the landscape for formal partnerships between local health districts and Aboriginal community-controlled health organisations across New South Wales is highly inconsistent. Can you, just for the benefit of the committee, sort of explain this further and whether any partnerships have been formalised so far?
Yep, sure. I'll get Margaret to respond to that.
Yeah.
Thank you.
Sure. Okay, so what we talked about in terms of the inconsistency of partnerships is around, in some areas we see very strong partnerships between the LHDs and the ARCHOs. Those partnerships are often linked to resourcing, and they involve clear outlines around the service delivery for the ARCHOs and how that works with the hospitals. In other regions, we don't see any partnerships, or we see very surface level partnerships that relate to just documentation. So, what we see in particular in some areas is where the LHD might have a partnership with a regional body, and the regional body may represent some of the ARCHOs in that region, but there needs to be an onus on the LHD to ensure that they have some form of partnership with every ARCHO, because we don't want to see any ARCHOs left behind in that system of care.
Yeah, absolutely. And you also note that there's a lack of representation of Aboriginal people in the senior levels of the LHDs. Do you think that actually having targeted positions or roles to increase representation, would be helpful for some of the issues that we've been talking about?
Yes, I do. I think that's very important moving forward, that Aboriginal people need to be very much in control of decisions that are made regarding the health of Aboriginal people. Peter and I are lucky enough to work for a fantastic CEO and Aboriginal board who direct the work of the AHNMRC, and I think that sentiment being included in the governance of the hospital system, yes, it's important. But I'd defer to Peter if he wanted to add anything to that.
No.
Okay. Okay. And do you feel that in places where there's an absence of any kind of formal partnership, I imagine that makes it very difficult to support patients in hospital and other healthcare settings. Can you give us any examples of some of the on-the-ground difficulties that you may have heard of arising from the lack of formal partnerships?
I think a particular difficulty that I have come across this year from our member services has been around the delivery of mental health services where there are not good partnerships. So it can, obviously, our member services are able to provide a level of mental health services to the community, but at times people will require acute care from a hospital setting where there is no partnership and there is lack of information sharing processes. That has been reported to us as being particularly difficult to ensure that in a time of crisis, people are completely supported the whole way through their journey. Because obviously health professionals are catching up on what's happening, and people then have a delay in the care that they're provided. Tina, did you want to?
Yeah, look, I guess what we see at the moment with the COVID crisis in Western New South Wales is that we don't, not having a formalised partnership with our Aboriginal Community Controlled Health Services with the LHD has seen this kind of disconnect of response around managing case numbers and supporting families and individuals' welfare. And so, we see the SHIOC committee, particularly in Western New South Wales, don't have Aboriginal community controlled, not even the CEO at the committee table to talk about the response in Western New South Wales. And I think, this demonstrates, the need and downfalls in this partnership, what we're trying to talk about here.
Yeah, and you mentioned also that by not having any kind of formal partnership, there could be also duplication of services as well. Can you give us a bit more information about that? Is that something that you're currently seeing happening on the ground?
Oh, look, there's definitely duplication of services from, LHD as well as our Aboriginal Community Controlled Health Services. So I guess what we're, wanting to look at is how do we, look at, tertiary hospitals are really focusing on, the tertiary needs of individuals, and community care type arrangement, community health should really be driven by, primary care providers, which is our Aboriginal Community Controlled Health Services. And so we want to be able to work with the LHDs or the local health districts to reorientate those efforts back into community control. And because again, that would demonstrate service integration, right? So we would say that, our services are working in tandem with the tertiary health needs of individuals from a hospital perspective.
Thank you. I'll throw to Kate Fairman.
Thank you very much, Deputy Chair. Kate Fairman.
Thanks, Jim. Thank you both for appearing today and for the good work that you do across the state. I just wanted to, I do think it's extraordinary that the government hasn't committed really to building these partnerships with the ACCHOs and the LHDs. I see in your submission, you refer to the New South Wales State Health Plan towards 2021, and that was that is a commitment in that health plan, which I think was written or released in 2014. So is it a situation that the government just isn't taking this seriously? Do you feel respected and listened to and able to influence New South Wales Health in this area?
Look, I think, we've had conversations in the past around developing a statewide Aboriginal health plan and partnerships, but it becomes, becomes a talking fest. We just go around in circles, right? So what needs to happen is that, and again, all our local health districts all have to comply as part of their national accreditation as a hospital, abide to the National Safety and Quality and Health Services Standards. And there are 6 action items that are specific to Aboriginal and Torres Strait Islander healthcare. And action 2.15 talks about working in partnership. So it clearly outlines what the hospital needs to do in terms of meeting their accreditation standards in working in partnerships in Aboriginal and Torres Strait Islander health. And in that point, it talks about having formalised partnerships with Aboriginal Community Controlled Health Services, as well as Aboriginal Community Controlled organisations. So, those other social and non-health related services as well, in terms of their accreditation. So, what we want to see, instead of having a national, a New South Wales plan, we want to see localised plans with our Aboriginal Community Controlled Health Services.
Because I think, is there also the situation which, oh, sorry, Ms. Cashman, did you want to also answer that? Okay, sorry, that was just when you're off mute, your phone rings. Is this also a situation, we heard this morning about the fact that the LHDs have KPIs which are largely around budgetary meeting financial KPIs. They're kind of operating within a system where they're they're not really trying to do things new and expand. They're just trying to keep within budget because that's their KPIs. Do you think that that would, obviously there's formalised partnerships, but KPIs around like engagement with art shows, KPIs that reflect what's in the state plan as well need to be put in place?
Oh, look, definitely there needs to be KPIs in the state plan that reflects the formalised partnership with our Aboriginal community controlled health services. But I also think that, if LHDs are concerned about budgetary constraints, then they need to really consider, well, what's their real purpose? So in terms of community-based care, they can certainly be provided by primary care providers such as Aboriginal community controlled health services. And, hospitals just really focus on, those tertiary and specialist care that, they're funded to do. What we know in terms of the activity-based funding model from the Commonwealth through to the states is that for an Aboriginal patient who enters a tertiary hospital, we know that there's a 3% loading that's applied to an Aboriginal patient. So they actually get, a 3% cap on an Aboriginal patient that comes in, because they know that Aboriginal patients have complex needs and social supports that need to be supported. And we know that that 3% loading could really be supporting our community controlled health services and providing, what they already provide, which is that comprehensive support and a holistic care that can be provided to that individual once entering into the hospital system.
Thank you. I just wanted to ask now a slightly different angle, but in relation to people becoming Aboriginal health practitioners, so making sure that there are enough First Nations people going to study medicine and nursing and, allied health. Can you make any recommendations in that regard, and are there problems in that area?
Look, particularly for Aboriginal community, Aboriginal and Torres Strait Islander health practitioners, there's not enough funding to support RTOs or training, registered training organisations to support, a young person to, be supported to do that qualification as well as to be coming out as a practitioner. So there certainly needs some funding and resources in that space. I know that, universities are changing the way that they, attract and retain Aboriginal students. We know that, for example, particularly in Dubbo, there's the Murray-Darling Basin funding that's been allocated to develop a medical program in Dubbo, where that's allocated for Aboriginal and as well as someone from a rural background to actually do a full-year medical degree in Dubbo. So there, those innovative programs that are happening, but we need to do it more broadly to attract, the other disciplines such as nursing and allied health in that space. And by ramping up, health workforce, you create a more culturally appropriate and safe environment for mob to enter into.
So just in that regard, do you think, is there kind of too much demand from Aboriginal and Torres Strait Islander people who are wanting to study or are studying in this area? Is there too much demand for the supported places available? Is that your experience?
In terms of support demand, my experience is that there's not enough, and we are, putting on my adjunct position with the University of Sydney is that, we're certainly advocating through the Commonwealth to make sure that there are more Commonwealth supported places for Aboriginal people to actually enter into those medical degrees or health degrees. There certainly needs to be more emphasis in targeted supported places, but again, that's just, we're advocating at the moment for that.
Thank you. I just now wanted to turn to the issue of kind of overall health and wellbeing and preventative health that the services that the art shows provide. Is there more funding needed for programs in this area generally? Are there any recommendations around that?
Oh, look, in terms of the services that our Aboriginal community controlled health services provide, they provide a plethora of programs and services. So, you know, when an Aboriginal person enters an Aboriginal community controlled health services, you know, they can come in for their health check, but also come for their own social and welfare needs, as well as other social needs as well, whether it's employment, training. It's basically a one-stop shop that actually looks at a holistic kind of approach to an Aboriginal care. But again, you know, our ARCHOs don't get funded enough to provide those other social support needs. The only funding that they receive is purely on their primary healthcare component. But we know that if you know, address the social needs of individuals, we know that one, they would be, you know, more productive in society, and their health outcomes would decrease if you look after the social needs. And that's what, you know, our services provide, is that comprehensive view around healthcare. But again, you know, they don't get funded enough for those social supports and programs.
Just my last question, Chair. This is just remind us the funding breakdown. Like, is it all standard across the state for ARCHOs, and a certain percentage obviously comes from the feds? Could you just quickly remind us what that is?
Sure. So probably 70% of their core funding comes from the Commonwealth, and then there's a small amount of money, about probably about 10%, or close to 15 maybe, comes from New South Wales Health. And then the rest comes from, you know, self-generated money and philanthropic opportunities that they endeavour into.
Thank you very much.
Thank you.
Thank you, Kate. Thank you, Associate Professor. We'll move the questioning now to the Honourable Wes Fang. Wes.
Thank you very much, and thank you so much for appearing today. I really do appreciate you taking the time to provide us some insights to the views of Indigenous people, you know, with rural and regional health, because I think it's vitally important that we get this right. And to that end, I noted in your introductory statement that you talked about culturally appropriate spaces and treatments. And can you just provide a little bit more elucidation on that, and what it is that you think that we might be able to do better to engage and work with the Indigenous population to make sure that we do that, but also if you can provide perhaps some insight as to how it is that we're currently engaging in that space. I know we've got like a checklist that that's been produced, and in your I guess real life experience, you know, on a day-to-day basis, how are those tools working, and do you think that there's need to either make changes to them, or, you know, if they're working well, you know, what about them is working well?
Okay, all right. So I guess in terms of when we talk about cultural safe care or culture appropriate care, we're talking about you know, systems and services that acknowledge you know, the history of Aboriginal people as well as their culture. And so that could be through you know, acknowledging that, you know, the lands on which the building is built upon. It could be staff, you know, entering into, you know, understanding cultural history through cultural awareness training or cultural immersion programs. It could be, you know, allocating spaces for Aboriginal people, such as a healing garden, or spaces where they're connecting to country. So that's when we talk. That's when we talk about culturally appropriate care. And on top of that, it's also about the health system acknowledging cultural-based practices. So for MOB, we still, you know, practice our traditional healing practices, and so that needs to be incorporated into whatever care that is given to an Aboriginal patient in the health system. So it's acknowledging that they have a right to cultural-based care. And I guess what's working, you know, well is that, you know, we do have, you know, some Aboriginal community controlled health services that, you know, work closely with, you know, Aboriginal staff members within the hospital to acknowledge those cultural-based care. You know, that's the kind of lower level kind of things that we don't necessarily see, but we hear about, is that, you know, we know that, you know, Aboriginal people have a strong kinship system. Whether you work in, you know, Aboriginal community controlled health services or you work in the hospital, they all have the same common ground, which is about, you know, the best care of their mob. And so they will work tirelessly to ensure that they're getting the best cultural care. And so I think it's important to acknowledge that. Just going through, there's multiple questions in that question.
I tend to do that. You know, I have lots of thoughts that are, you know, running around. I like to just get them all out there and then see what transpires, and then I like to, you know, elucidate on some of those positions. So if you need something repeated, by all means. I think the bit that I was asking about that I'd be keen to know is that we've got the Aboriginal Cultural Engagement Self-Assessment Audit Tool that the New South Wales Health has put out there, and I'm just curious as to your experience, perhaps having worked with it. I don't know if you have or not, and if you could provide some feedback as to how it works and how those tools that we have as New South Wales Health or the New South Wales Government are helping the services and also the groups that are stakeholders engage and connect.
Look, I think it's important to note that, you know, yes, you can have tools to kind of, you know, tick off about, you know, whether or not a health service is being culturally appropriate. But at the end of the day, it's about, you know, people and services working closely with community on the ground. When we have people that develop checklists, it really becomes a tokenistic kind of gesture to say that, yes, you know, we've ticked all these boxes to say, yes, we are culturally safe, but are you really? And the only way to measure cultural safety is by actually yarning with elders and community members about, you know, their experience of the healthcare system, and also seeking their advice and the guidance around what strategies should be applied within the healthcare system. You know, we often, you know, dismiss elders and community members when we come to develop, you know, strategic plans or health plans. You know, we should be, you know, working with and working together with elders and communities to design, well, what is the health system they want to see? What are the things that they need to support them whilst they're navigating the complexity of the healthcare system? And so I think it's important that we now, you know, when we develop, you know, state plans, is that we take an active listening role to community and actually hear what they want.
It just struck me actually as you were answering that you were talking about you know, how it could be tokenistic to have these tools, and that, you know, what we really need to do is engage and yarn with each other to find out how it's working. And it sort of dawned on me that that's exactly what it is that you and I are doing now, where you know, the tool is there, but what we do, you know, what I'm doing is I'm asking for that lived experience and how your engagement with the tools that New South Wales Health has actually either increased that feedback loop and ability to interact, or whether it could work better. And yeah. So yeah, that's almost what it is that we're doing now. Has that been happening at all? Like, not only from me, but from, you know, other members of the government or people within New South Wales Health, getting that feedback loop about the tools that are being put out there in order to try and increase that cultural awareness.
Look, we've certainly heard from on the ground that the tool hasn't been useful in terms of building the relationship with Aboriginal community controlled health services as well as the community. And so, you know, I guess that's the fault of, you know, people that develop the tool, is that there hasn't been a co-design process with Aboriginal and Torres Strait people. And so that needs to occur. The other thing here is that we know that New South Wales Health have developed the Respecting the Difference program that looks at cultural kind of awareness, but we know that in New South Wales there are many traditional language groups, and you can't just develop a training material that is standardized. And I think if we're going to develop, genuine partnership or having a genuine dialogue with community, that we develop localized cultural awareness programs that the local health districts can access. And we certainly are seeing that with Waminda. Waminda has the cultural immersion program in which their local health districts staff participate in. There are things happening across the state, but we want to see it more, and we're not respecting the different as a mandatory requirement, but more cultural awareness, mandatory requirements that are that staff utilize local content instead of the just generic program.
So do you think it's fair to say that in the past, say, 2 decades, 3 decades, that we've seen an improvement in the way that the health services that the New South Wales government provides have been more focused on being culturally aware and culturally appropriate to Indigenous people? And how do you think we've been progressing in that time? And what do you see as, other than just, I guess, making it more localized, what else do you see is important for us to focus on into the future?
Yeah. So again, I guess it gets back to the fact that there are some, parts of New South Wales Health that have, started the dialogue with Aboriginal communities and to develop, a shared kind of approach in developing cultural safe practices or strategies. But I think what we need to do is actually have, a genuine conversation about how do we, develop not just an Aboriginal health plan, but an Aboriginal health plan that steers and redirects the health system to be culturally safe and responsive. And that's about how do we develop stronger and formalised partnerships with our Aboriginal community-controlled health services. And, what we want to also see is that a genuine dialogue with our Aboriginal community-controlled health services CEOs in those communities so that they can be a part of the hospital's health service planning, as well as other activities that the hospital may be venturing into. And so I guess it gets back to that point of this, re-establishing those formalised partnerships. But I might pass it on to Margaret if she has any comments.
Thanks, Peter. I guess the only comment that I would make is it just goes, when you're asking the question of has New South Wales Health improved in, its delivery of culturally safe care, it goes back to we really need to ask the Aboriginal people in the communities who are accessing that care what that looks like. And that speaks to, again, looking at the hospital having a role in or accountability in their engagement with communities, with ARCHOs, with CEOs, all of those things. Yeah.
No, thank you very much for providing, I guess, that feedback, because it is very important for us. And look, it's important across the whole aspect of the different cultures that we have within New South Wales. And I think that if we can improve aspects here, then we can improve it across the whole spectrum, and that's something that is important to making sure that we have timely and correct healthcare provided to people all across this state. So thank you very much for the feedback and your input. Jeff,
thank you very much. Thank you, the Honourable Weatherspoon. It was very, very good. Number of important questions there, and the answers have been very fruitful. Can I take this opportunity to thank you both once again for making yourself available. It may not have seemed to be a long period of time on the clock, but we covered a fair bit of terrain. And I think when we sit down and look at the Hansard, and the next day or so, we'll see there's a lot of rich information in there, which will help inform our considerations around the drafting of the report and its recommendations, which will obviously be also taking into account your contribution through your submission. So once again, on behalf of the committee, can I thank you both and thank also the Aboriginal Health and Medical Research Council of New South Wales for all the most important work it does for and on behalf of our Indigenous brothers and sisters across the state. Thank you very much.
Thank you, Chair. Thank you.
Thank you, Chair. Thank you.
Thank you. Okay, well, we've got a short changeover now to the next pair of witnesses. Go away, and we'll be back shortly.
It's Andrew here from the Secretariat. Both witnesses are in the lobby, so if you're ready, we'll now admit them and check their connection.
Thank you, Andrew. That would be good. Thanks a lot.
Hello, Dr. Stevens and Professor Searles. It's Andrew here from the Secretariat.
G'day.
We are live. Hello, we are live and we'll be proceeding in a moment. I'll check your sound one by one. Dr. Stevens, can you hear me?
Loud and clear, Andrew. Thank you.
Thank you. And Professor Searles, can you hear me?
Yes, I can.
Thank you. Please have your oath or affirmation ready. Also, when answering questions, please first state your name for the benefit of the Hansard reporters. You can now mute your microphone until prompted. Chair, when you're ready, please proceed.
Thank you very much, Andrew, and a warm welcome to our next two witnesses this afternoon. And can I take the opportunity to introduce, first of all, Dr. Alex Stevens and Professor Andrew Searles. Gentlemen, we'll need to get through the formality first, which won't take very long. So it involves individually you introducing yourself by stating your full name, your position title, and then swearing either an oath or affirmation, whichever you prefer, the words of which should be have been provided to you. If for some reason they've not been received, just let us know and we'll forward the words for either the oath or the affirmation to you. So if we could start with Dr. Stevens.
Thank you, Chair. My name is Alex Stevens, and I am the Director of Research for Northern New South Wales Local Health District, but I'm appearing before this committee in my capacity of the Chair of the New South Wales Health Research Alliance. I will do the affirmation. So I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. Thank you, Chair.
Thanks very much. Thanks very much, Dr. Stevens. And can I pass over to Professor Searles?
Thank you, Chair. My name is Andrew Searles. I'm Professor of Health Economics at Hunter Medical Research Institute in Newcastle. I will take the affirmation. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. Thank you.
Thank you very much, Professor. Can I commence by acknowledging the submissions that have been respectively made? So, Dr. Stevens, you would probably be aware that your submission has been provided, received by the committee secretary, processed, and stands as submission number 182 to the inquiry. And Professor Searles, likewise, your submission has been received, processed, and stands as submission 467 to the inquiry. What that means is that both of those therefore stand as evidence before the inquiry that's been made by submission. And we're grateful, the committee is very grateful for you both this afternoon to provide us with the opportunity to receive some oral evidence from you, which will arise no doubt from committee members wanting some matters elucidated from your respective submissions, but also I think just the dialogue that we have and the questions that will emerge arising from that. So in making your respective opening statements, there's no need to in detail refer to your submissions because you can take them as read by the committee, but just a few minutes of an opening statement from both of you, and that will set up then nicely the questioning which will take us through to the end. So gentlemen, are you okay with that format for this afternoon? Thank you.
Yes, thank you.
So if we start with Dr. Stevens with your opening statement.
Thank you, Chair. Thank you very much for the opportunity to appear before the committee. So as noted, I am Dr. Alex Stevens. My substantive role is the Director of Research at Northern New South Wales Local Health Districts, so LHD. But today I appear before you as the Chair of the New South Wales Rural Health Research Alliance. Briefly, a bit about the Alliance. So the Alliance was established in 2018 to grow research in rural, regional and remote New South Wales and support the generation and use of robust research evidence with the view to improve the delivery of health services and create healthier communities. So the Alliance is strongly supported by the Rural LHD Chief Executives, and the steering committee comprises of representatives from each partner LHD, and that's typically the research lead. So the Alliance's submission to the inquiry focused on the existing evidence on markedly poorer health in rural, regional and remote areas. So higher rates of emergency department use and hospitalisations, poorer health risk factors, higher mortality rates and lower life expectancy highlight this. The submission also cited research investigating the role of social determinants in explaining some of this evidence. So the submission, in terms of the socioeconomic status, looked at the role it played in explaining some of the inequalities and in particularly life expectancy. So it highlighted some research that showed that once socioeconomic status was adjusted for, life expectancy differences between metropolitan and rural New South Wales were minimal. So this research, combined with other existing studies, suggests that a person's position in society, their living conditions and opportunities for education and employment have a direct bearing on their exposure to risk factors for disease and poor health that ultimately impact their life expectancy. So this describes the contemporary view of health through the lens of social determinants. So all this serves to highlight the crucial role research should have in addressing the current health inequalities in rural, regional, and remote areas. So research through a comprehensive health informatics and data analytics platform can systematically map burden of disease by key socio-demographic factors, such as socio-economic status and remoteness, to better understand areas of greatest need and establish priorities. So through this strategy, dedicated investment into the application of current evidence-based program to systematically address the underlying causes of inequalities in these priority areas can be planned and delivered. In line with the research paradigm, such programs can be comprehensively evaluated through a combination of qualitative research to understand the experience and process of implementation, and also quantitative research to objectively assess outcomes. Collectively, this evidence-informed approach represents a strong framework upon which meaningful change can be introduced, implemented, and assessed in rural, regional, and remote New South Wales. Thank you, Chair.
Thank you, Dr. Stevens. That's set things up very nicely, I believe. There was some questioning in a moment, so very good. Professor Searles, would you have an opening statement you'd like to give?
Thank you, Chair. So honourable members, thank you for the opportunity to participate in this inquiry. I'm strategic lead of the HMRI Health Economics team, as I've already stated. We're a unique team in regional New South Wales and also in Australia. Our remit is to work with health services and health researchers to understand the costs and the consequence of health technologies that are used in our system. This work is a means to determine the value of healthcare that is provided to patients. When I talk about health technologies, I'm including devices and medicines. Now, at that level, they tend to be very well evaluated, particularly at the national level. But I'm also referring to models of care, diagnostic tests, right through to health policies and public health initiatives. My focus is the healthcare deployed at the local level in health districts, hospitals and primary care in urban, regional, rural and remote New South Wales. And at this level, evaluation has typically not been optimal. Today's evidence that I'm presenting draws on a report that we conducted, a national report, and it was titled The Local Level Evaluation of Healthcare in Australia, and I believe this has already been provided to the committee. To be succinct, some key findings that I think will be relevant to this committee are, firstly, despite Australia having excellent national and state agencies to evaluate healthcare provided to patients, we have a gap in evaluating healthcare delivered at the local level. 2, local level evaluation is important to account for local context. For example, differences in demography, patient draw areas, healthcare resources, geography, and disease burdens. Local context is important because the models of delivering healthcare that we might use in Bondi may not work in Broken Hill. 3, health services have been clear to us that they want access to evaluation skills and they want capacity building in evaluation and implementation amongst their own staff. And we conducted national work to identify the evidence behind that statement. Fourthly, Evaluation provides evidence for decision-making as to whether a health technology should be introduced, retained, or removed from the healthcare system. However, health services have problems accessing the required skills, and some of these skills include, that are in short supply, skills in evaluation, implementation, and health economics. My fifth and final finding that I think is relevant to the committee is that there is a lack of evaluation and monitoring post-implementation. And what I mean by that is that after we've introduced it, we don't always follow it up to see, is that technology delivering the benefits that we thought it was going to? Our national report had 4 key recommendations. Firstly, to develop national standards for evaluation to ensure a uniform approach to evaluation of healthcare across local health services. 2, to boost education and training and professional development in evaluation and implementation within the health workforce, particularly amongst clinicians and managers. Thirdly, increase the available workforce of skilled evaluation and implementation staff at the local level who are integrated with health services. And fourth and finally, to make the funding for evaluation and implementation sustainable at the local level so that local health services can use these services in decision making. Our team are implementing some of the more detailed recommendations from our national report in 3 New South Wales local health districts and a primary health network via a medical research future fund program called the Embedded Economist. The Embedded Economist was designed based on the needs that were expressed to us by health services, and it places a health economist within the local health service specifically to work on projects that have been selected or prioritised by that health service, and it is currently being independently evaluated. The report that I referred to earlier provides greater detail than I have provided in this statement, and I also would like to thank you for the opportunity to present to the committee.
Thank you, Professor, and that too is a very fruitful opening statement, which I'm sure is going to lead to a number of questions from committee members. So we'll get our questioning underway. It'll be approximately about 12 minutes per group. So we'll start with the opposition, the Honourable Walt Secord.
Thank you, Mr. Chair. Thank you, Dr. Stevens, and thank you, Professor Searles. Dr. Stevens, just so I can get context, so is your alliance, the New South Wales Rural Health Research Alliance, funded and administered by New South Wales Health?
So we are currently an in-kind network of research representatives from all of the rural local health districts in New South Wales. So there's 7 of us. We were formally funded when we formed in 2018. It was modest funding, and we had enough funding to support a program manager being in place. There is currently a review of research structures in New South Wales, and as part of that review, the funding for the moment has been paused, and we remain an in-kind network.
Okay, but you are the 7 local health districts. You are under the cloud, not under the cloud, but in relation to the local health districts.
We are from the local health districts, that's correct.
Right, okay. So you do answer to government, and you receive your funding and assistance from government. So I just want to take you back to your opening statement. So you said, now I don't want to put words in your mouth, so please clarify this if that's the case. You said taking aside social determinants, you didn't see that there was a difference between rural and metropolitan health outcomes once you take aside social determinants. Is that correct?
So that's only one view of it, and the research was based on data collected quite some time ago, but what it introduces the concept of social determinants as being a driver of some of the health inequalities that we see. So it's basically suggesting we need to look at it from a slightly more sophisticated level than just saying that there are health inequalities. We need to understand what are the drivers, what are the causal factors which account for the inequalities. Okay. Social determinants in the context of life expectancy probably plays a large role, and maybe for other population health metrics, but it's not the sole thing that contributes to health inequalities.
Okay, but you were making the case that taking that aside, that there was no difference between rural and metropolitan outcomes once you take that out.
Just for life expectancy, and once you adjusted for it in the methods that we used, it accounted for the bulk of the inequalities, apart from the most deprived population living in the rural areas still had a large difference between their sort of equivalent socioeconomically ranked counterparts in metropolitan areas.
Okay, so I'm trying to get to the point so that your research is not making excuses for the state government to say that the health outcomes are not different in rural and regional areas and city areas. That you're actually
I'm going to take a point of order in that. That question implies that the research is somewhat controversial, and I think that the Honourable Court has the right to ask questions about it, but to make implications to these two witnesses is probably a little bit beyond the pale.
Mr. Chair,
to the point of what I think perhaps maybe a small reconfiguration of the question will deal with this. So just bounce back the question and see where we go.
Okay, well, I actually like to thank the Honourable Wes Fang for actually getting to what I was actually trying to get to. So I'm actually trying to make the point that is your research to improve health outcomes from rural and regional families, or is it to make excuses that there are not adverse outcomes in rural and regional areas once you take aside social determinants? I put to you that in fact you're just making excuses for the disparity between rural and regional health.
Let me be perfectly clear that the research is in no way designed to make excuses for the health inequalities that we see in rural, regional, and remote areas. What it is highlighting is that there are underlying causal mechanisms that need to be explored and understood to then develop solutions tailored to addressing the causes of the inequalities.
Okay, and I see in your submission you identify the consumption of sugary drinks in rural and regional areas as one of the reasons for poor health outcomes. Can you elaborate on that?
So that is sort of superficial evidence to support the argument that social determinants has a role in explaining some of the inequalities that we see in metropolitan versus regional remote areas, right? Social determinants in itself is quite a complex concept. And what it does suggest, if I can explain it very briefly, is that there are social and economic conditions that act as preceding factors that influence health behaviours, lifestyle choices, access to care, opportunities for education and employment that themselves have an association with adverse health outcomes.
Okay, so in rural and regional areas, as you said in your opening statement, there are higher visitation to emergency departments. Why is that?
Well, I think you probably need to explore it in a deeper level. So we do see that there are higher rates of emergency department use, but we also see that there is a lower density, for example, of primary care. Now, I cannot definitively answer that there's a causal mechanism there, but there's a plausible mechanism that you could use to undertake an activity, a research project, to try and understand whether that is a driver or not.
Preventable diseases.
That's just emergency department hospitalization, but you can explore, if you have a look at the fundamental principles of primary care, which is largely around the first point of call for people seeking healthcare. They provide a comprehensive suite of services, preventive health, mental health, chronic disease management. If you've got lower levels of that, what are the implications, right? If you cannot prevent disease progressing, if you cannot prevent disease at all, disease develops, for example, you get higher rates of ED usage, you get higher rates of high acuity ED usage. So they're the types of things I'm suggesting are worth exploring to definitively reveal in a way what the causal factors are to then tailor solutions to address them in a robust and scientifically rigorous way.
So, Dr. Stevens, so in rural and regional hospitals, what is the most common condition that families or people in rural and regional areas are being hospitalized for?
Look, I couldn't tell you, but it's very similar in a way in terms of what people need hospitalization or hospital care for in rural areas than metropolitan areas, right? All the major diseases are still the same. What is the biggest difference is the population burden of disease in regional and remote areas, and the rate at which it develops. So you're more likely to present with illness earlier in regional and remote areas than you are potentially in highly affluent areas in metropolitan centres. And as the population distribution, so the burden is likely to be greater as well. But look, these are only my words, and there's probably an approach to identify this data, to source it, to definitively answer your question. And I don't have that answer.
But can I take you back a step? So you said that people will present to hospitals earlier in rural and regional areas. That's not the evidence that we had in other occasions. We had that people are reluctant to go to hospitals because they find that there's a lack of confidence in rural and regional facilities. So you have hospitals that don't have doctors on the weekend, that you have hospitals where you have to wait. Earlier evidence today, 4 days to get a specimen or a sample or a test back.
I'm sorry. Sorry, the Honourable what's it called making assertions here that I am struggling to actually identify those indications that we've had during this inquiry. I think that they're very broad generalisations, Chair, and I'd ask you to direct into a more direct question.
Well,
Mr. Chair,
with the greatest respect, the Honourable Secretary is in order with his question. Please proceed.
Thank you, Mr. Chair.
So what I will say, if I made a reference to them seeking care earlier, probably it wasn't correct. What I was alluding to is that disease is more likely to develop at an earlier stage. And I'll substantiate that by basing it on research that I undertook, exploring the consequences or the contributing factors to lower life expectancy experienced by people living in rural and regional areas. And you see that they're basically dying from the same common conditions that we see in metropolitan areas, so chronic diseases, cancers, and so forth. But the contributions are due to illness occurring earlier in life. So the disease develops earlier than you might expect in metropolitan areas, potentially in more affluent centres.
Mm-hmm. Professor Searles, in your health research economics, do you do modeling on productivity and the impact of preventable diseases in rural and regional areas on the economy and economic output?
We haven't done specifically that type of modelling, but we are working with one of our local health districts to increase their focus on prevention for productivity reasons. And the idea being it's more cost effective to identify disease earlier in its cycle and address it then, rather than waiting until the disease has progressed. And then, of course, people need more intensive and more expensive, usually hospital care.
Thank you, Professor Searles. That you actually answered my question. So, do you, in fact, what are you finding that every dollar you put in early results in a saving or a benefit to the community down the track? What are you finding in that area?
Okay, so what we have looked at, we have not done that specific modelling, but we have borrowed information that's been put out by the Productivity Commission in Australia. Mm-hmm. And one of the key gaps we have in Australia is that there has been very little work done on evaluating preventative care. And as a consequence of poor evaluation in that space, Australia has tended, compared to other countries overseas with similar health systems, we have tended to underinvest in preventative care. So this is you're absolutely right, it is a productivity issue. So if we can identify where we can get the best value from putting our health dollars, of course, that can help decision makers determine where we should be allocating them. And that's where health economics can come in, but it's a very broad area. Our focus has really been, identifying the existing literature. A lot of it comes from the Australian Productivity Commission, and then working with local health districts to identify how they can actually increase their focus on prevention.
Thank you, Mr. Chair. I think that's my time.
Yes, it is indeed. Thank you very much, Honourable Secord. We move now to questions from the crossbench, and I'll call the Deputy Chair, Honourable Emma Hurst.
Thank you, Chair. I'm just going to go to Professor Searles first. I mean, I was quite shocked to hear that there was sort of no evaluation that was being done, particularly on new health technologies that were being brought in. But also, I think in your submission, you also highlighted that even when new health technologies enter the health system, that there's often no assessment of patient benefit. What does this mean on a practical sense? Does it mean that we've got hospitals with technologies that they're not using, that aren't useful in those particular locations? And what does that mean, broadly?
For a correction, we're not saying that there is no evaluation. We're saying that the evaluation is not optimal. And because it's not optimal, we have many health technologies, that actually have come into the system in past times where they've never been evaluated. They have come into the system and they've remained in the system and just become part of the way that we do things. They may be effective, they may not be. And because it's not been evaluated, we can't be too sure. More and more, and particularly with agencies like the ACI within New South Wales Health, there is now more of an ethos in terms of ensuring that new models of care and technologies are evaluated so we do know what those patient outcomes and patient impacts are going to be. However, there is still a shortfall, and we work with our local health districts to try and identify ways that we can build into the system routinely collected data so that we can actually see if somebody has been exposed or have utilised a particular model of care, what are their downstream impacts. So often what happens is we do the initial evaluation for a model of care. It might get a tick because initially it is deemed to be cost effective under trial conditions, but real world conditions are often very different. So it might be that in the trial that we've got very strict criteria for how a particular technology is being rolled out, whether that be how patients are taking medications, or it might be for diabetes control, it might be how we actually bring patients into the system. Under a trial, that can be really rigorously controlled. When we move to the real world, things don't always happen like that. And it's the real world outcomes and impacts that we're particularly interested in. And we're particularly focused in trying to help health services routinely build in those kind of metrics that they can actually say, we're not getting the benefits from this model of care that we thought we were going to.
And the best way to optimise those evaluations is going back to what you said in your opening statement. You sort of made a list of evaluating and training for evaluation, increasing funding for evaluation. That list is how we get to optimise that on that sort of ground level.
Yes, that was sort of the overall picture. Our report has some more detail in how to get that, and there is quite a bit of detail that goes into this. But one of the points I would like to make is that in our national work, so that's not just New South Wales, it was across Australia, that in fact the health workforce are actually very interested in evaluation. So these are clinicians who are at the coalface who actually want to know how to evaluate what they're doing, but they don't want that to be the prime component of their job. So they need some help in how to do this. And in a way, it's actually building in my view, it's building in evaluation as business as usual.
Thank you. Dr. Stevens, in regards to your research around, and you talked about these social determinants, and I was wondering if, when you were looking into these social determinants, whether you had assessed at any point whether there was a correlation between certain social determinants and rural or regional areas, or whether that kind of splits depending on the area, and if you could kind of explain that out further in regards to correlations that came up in that data set.
Yeah, so the approach to the work was about really defining how socioeconomic status worked separately to remoteness. So it's a term we use, for example, when you undertake a statistical analysis that you adjust for it. So to sort of describe it is to create sort of strata groups that represent combinations of remoteness and broadly socioeconomic groups. And once you do that stratification, you can assess in a way the independent effects of socioeconomic status versus remoteness. So part of the reason for doing that work in my research is that's commonly not an approach that's sort of taken. And in a way, it probably reveals one way to try and separate socioeconomic status from remoteness effects, because they're probably two slightly different things. When you look at geography, you probably look at distances, access to care, and whether you have healthcare services in the area. When you're looking at socioeconomic status, you're looking at more things like social determinants. It's your material wealth, your income, your housing, your education, and your employment, right? So the whole reason behind the analysis was to separate them. They are correlated because it just happens that there is an over proportion of disadvantaged Australians living in regional and remote areas.
Yeah. And with the data set that you came out with, was it largely sort of correlational based on large groups of people and being assessed, or were there causations coming through as well? Yeah.
So these are population-based data sets. So for example, the life expectancy work is based on the Register of Death, Birth and Marriages. If you look at some of the other sort of administrative data collections, you can look at hospitalizations, emergency department presentations, and so forth, and you can do the same type of work. It's epidemiological in nature, so we don't have the luxury of being able to identify the causal factors, but we can identify the associations.
Okay, thank you.
Thanks, Deputy Chair. Kay Fairman.
Thanks, Chair. I just wanted to go to what just basically some allegations that we have heard throughout this inquiry, if you like, about there being a culture of silence within New South Wales Health, particularly in relation to complaints that medical staff make about the system and ways to improve the system. Often they say that it's actively discouraged and also usually ignored. I just wanted to just get a sense whether that's the situation within your research organisations, whether your researchers have also, so if they're kind of uncovering or finding situations that need to be improved, how is this being accepted by the LHDs and by New South Wales Health? Is it accepted with open arms? And yeah, I just, if you could be just as frank as you can, that would be wonderful. I'll go to you first, Professor Searles.
Thank you. So look, our experience has been, because we work on the ground with clinicians, and I come from, just to let you know my background, I come from the private sector. So I've come into this role with an understanding that if you want things to change, that you often need to put a business case forward, and you need to have a good case as to why we should stop going in this direction and perhaps pivot. So my experience in working with clinicians is quite often the business cases weren't necessarily what decision makers were looking for. So they didn't always clearly identify what were the costs and the consequences from a particular course of action. And that's nobody's fault. That's not part of the training process that a lot of clinicians go through. In fact, it's not part of the training process a lot of health managers have gone through. So part of what we're trying to do is to get the clinical information, to understand the costs of a particular technology, and to bring them together into a short and concise business case that can go to decision makers so that they can see, if we make this decision and we're making a pivot to either remove or to bring something new in, this is what the likely outcomes would be. We also advise our colleagues in the health services, don't just rely on that first pass. Also identify how you will actually follow that up. So if we're saying we're going to remove a technology because the evidence for it isn't clear, how do we know it doesn't creep back into the system? And what will we do to make sure that we're monitoring that so it doesn't creep back into the system? If we're introducing something new, what is a particular metric that we might use so that in 2 years' time we can see, is it actually delivering the benefits that we thought it was going to? So none of this is rocket science, but it's bringing a little bit of that, what I would sort of say that a business way of approaching a problem and bringing it into the health workforce as well. So that's been our experience. My personal experience has been that if we can actually help clinicians put that business case together so that it's based on evidence, it also shows costs, that they've got a very good chance of convincing decision makers for the way that they would like it to go.
So can I just check, Dr. Stevens, do you have anything to add to that? I've got a follow-up question for Professor Searles, but you go.
I don't have too much to add apart from being slightly complimentary, I guess, to what Andrew is saying and have a spin on it from the rural and sort of regional perspective. I think what Andrew's talking about is developing a robust and rigorous framework to guide change if we're going to go down the path of doing it. We've just got a general lack of capability and capacity to do that in regional and rural areas. And some of the work Andrew is doing in the HMRI embedded in local health districts is fantastic examples of what you can do in that space. The only other thing I'll say is that we are slowly becoming more innovative in regional and rural areas. We've got, each of us have rural research directorates. There's also broad encouragement across a number of structures, New South Wales Ministry of Health, the different pillars to engage in continuous quality improvement. That does occur, but probably not in the rigorous way that we would want. Just like Andrew was talking about, we just don't have all the puzzle pieces there to do it rigorously.
So it sounds like, I assume there'd be quite a few GPs, for example, clinicians who don't go through your organisations or don't seek assistance, for example, with the business plans that you were saying, Professor, in relation to like their chances are a lot more improved if they go through you, but many wouldn't know to do that. Many wouldn't, approach you.
So we've also been working with our local PHN, Primary Health Network, to within their staff. And I think one of the things that I'd like to say is that I don't believe the skills that I'm talking about, they're not only found within health economists. So I believe that it's a very generic skill that we can actually share across the health workforce. And you might find some pockets of expertise in not only doing the evaluation, but communicating them. So communicating them is really important. So when you get the results, you can't give somebody a 500-page report and expect them to make a decision on it. It just won't happen. You want a business case, 3 pages, absolute maximum, that identifies the core findings with appendices if you do need that. So our work, we're only a very small team, so we do work with the PHN. Most of our work is with the clinical workforce within the LHDs, as it is now, we're run off our feet. We're beyond what our team can satisfy.
Yeah, that was kind of leading to my next question, actually. And thank you. I want to thank you both for your submissions, and the points that you raised in your submissions are very well, received. So I'm not kind of exploring those as much. My question is around the funding and effort that goes into medical research, particularly obviously in relation to rural health. And my next question is going to be about Aboriginal health. So maybe if both of you could address that. And yeah, I assume more needs to be done. Professor, if you've just said you've got, that you can't do everything that is there for your small team to do.
So part of what I believe part of the solution is this is where the education and training comes in. So we actually do and have worked with a number of Aboriginal organisations, not only in New South Wales, but also in North Queensland. And so my view is that training and capacity building is essential. So the way that I express it and I go into health services myself, it's not just my team members, but when I go in, I often say it's like calling a plumber into your house, that you'll point to the problem that you've got. We will go and work on that problem. I'm not bringing my research to do in the health service. I will work on the health services problem. But in addition, I will show you what I am doing so that if you have staff on board that are interested in doing this, we can go from that problem so that they can start to do it elsewhere. And the example that I have is with the local PHN. I spent 3 months sitting with our local PHN. The very beginning evaluation was very new for them. After I left the PHN, I showed them how to do a very basic cost-benefit analysis, which is a form of business case. And a couple of months later, I was sent an email from our local PHN. Would I review their cost-benefit analysis that they were putting forward to the Commonwealth? And it was a really nice piece of work. It was a really concise business case of what it is that they wanted to do. And to my way of thinking, that should be the philosophy is what we're trying to do. It's not building up a whole lot of consultancies. It's actually upskilling the health staff because they really do want to be able to do this themselves. There are times when you need arm's length between the person doing the evaluation and those providing the service. And I think there's a little bit of a grey area as to where that is. But clearly, when they're large investments, you probably do want an external person doing the evaluation. But for many of it, if we're going to make this business as usual, we want the health staff to be generally, even if it's only that they know what the evaluation is entailing, so that when they go out and ask somebody to do it, they know what they're asking for.
Yeah, that's a very good point. Dr.
Thank
Stevens,
you.
did you have anything else to add there? Sorry, Chair.
Just to add very briefly, so in terms of research priorities and I'll speak to this from the perspective of a local health district in rural and remote New South Wales, is that undertaking research that will assist the LHD in meeting strategic objectives is a priority, and that's a priority for me in my role as the Director of Research for my particular LHD. I think the issue of funding is complicated. It's a very sort of competitive space, but I think we're working strategically to try and promote, I suppose, in a way, research that will assist health services in meeting their core functions in terms of delivering healthcare. And I can speak from the perspective of the Alliance. We're working very closely with the Office of Health and Medical Research to develop a research strategic plan for regional and remote areas, and also working closely with them to be able to deliver on the recent sort of Medical Research Future Fund grant to improve access to clinical trials in regional and remote areas.
Thank you very much, Doctor. Can we move to the Honourable Wes Fang, who I think's got some questions? Wes.
Absolutely, Chair. Thank you very much. Look, I could sit here all day and ask questions of Dr. Stevens about his research because I think it's fascinating. Dr. Stevens, I was actually hoping that you might be able to provide just a bit more of, I guess, some of the meat that you've had from the research. And in the short amount of time we've only got a few minutes left.
Take your time. You're okay.
Sorry. Oh, thank you.
You're okay.
Thank you, Chair. I appreciate the latitude. Just some of the, I guess, the take homes that for those people that aren't able to dive right into it, what it is that you see as the real take home messages from what it is that you've been researching.
Look, I think my research is just one small example of a general approach we should take for better defining and identifying what the real problems are in terms of explaining those health deficits and that health divide between metropolitan and rural areas. To be perfectly frank, I'm quite far removed from my research. My day job takes up all of my time and I have to do my research basically as a hobby. Mm-hmm. But the underlying principles are that it's a complicated issue. Right? There can be differences in health between metropolitan and rural and regional areas. That is fact. It's out there. There's a number of different metrics you can look at that provide strong evidence just to show that, right? The next challenge, I think, is being able to take the next step and determining if we are going to make a change to the way that we deliver healthcare or do anything in regional and remote areas to act on that deficit and potentially improve it. How do we go about doing it? It's going to be a complex issue. It's going to be permeated by social determinants. And this very inquiry has revealed throughout its course also a number of issues, which some of them may be anecdotal, some of them may be based on more sort of thorough, high quality evidence, but they're all things potentially that are worthwhile investigating. I guess it's up to you as our elected members through this inquiry to make recommendations as to the next steps. I would basically just kind of advise that this is the starting point. We can highlight what the issues are, identify the priorities. We need to drill deeper to then tailor solutions to best address them, understanding that we operate in a world where we have finite resources, they're not unlimited. And then some of the work that Andrew is doing really nicely sort of complements what I've been suggesting, is that we need to understand if we're going to do something, what's going to result in the greatest impact for the best cost or return on an investment, and that we continue monitoring and evaluation through the capture of routine data.
So I think what you're effectively saying is that a lot of the issues are complex, and that that those people who seek to simplify it down to a soundbite, for example, are probably not doing justice to the complexities within it. Would that be a fair assumption?
I would say that's 100% correct. We can even look at the sessions run today, right, with the cancer inequalities this morning, with the medical executive council and the Indigenous health, and now what we're talking about now with the research. They all highlight that there are sort of probably different drivers all contributing to some of the health deficits and inequalities that we see. So yeah, I would suggest it's a complex issue, but we need to probably take a prudent scientific approach to be able to, I guess, equip us with the tools necessary to address what are the biggest gains to be had.
Oh, okay. And then look, in the last minute that we've got before we end, I just wanted to ask you, how would you respond to like those who might seek to make political gain out of attacking research and you know that you might have made in order to further their political agenda?
Well, I would probably just recap that what I was trying to communicate is that there is a complexity to the health inequalities. And my example there of adjusting for socioeconomic status in no way discounts that there is a health deficit observed in regional and remote areas. It just reveals that there's probably an underlying complexity there that may account for that particular metric of population health, right? That is one of many metrics. It's just sort of introducing the concept that we need to leverage off research to identify what the causal problems are.
Okay. No, and look, my take home from that is that you think that, you know, obviously they're trying to simplify it, and no, it's not simple. It's quite a complex issue. But thank you so much for your evidence today and the research that you've done and providing some time to give us some insights today. I very much thank both of you for coming today and assisting us.
Pleasure.
Thanks, Honourable Westphang, and that brings us, gentlemen, to the conclusion of our period of time for questioning you. It's been a very, very fruitful exchange, and I think in the questions there's been much argument and much thought behind the questions, and the information come back has been very detailed, such that I think there probably will be, after members have had a chance to read Hansard, possibility of some supplementary questions, and if you're agreeable, what would normally happen is the Secretariat would liaise with you with a turnaround time of 21 days in regard to those supplementary questions. So once again, on behalf of the committee, I know, gentlemen, you're both very busy, and we thank you for making time available this afternoon for us to provide some oral evidence. Thank you very much.
Thank you for the opportunity. Thank you.
Thank you, Chair. Thank you, committee.
Indeed. So that brings us to the conclusion of our hearing today. We do have another hearing tomorrow, commencing at 9:15 a.m. So we look forward to people, if at all possible, can join us tomorrow and continue to follow the hearing across the course of tomorrow. I'll just check with the Secretariat whether there's any matters you'd like to raise before we conclude this afternoon. Vanessa, was there anything, or Sharon, that you'd like to communicate to us, or?
No, but we will have a short deliberative after we finish the public session.
Thanks very much, Vanessa. So I just draw that to committee members' attention. Please don't go offline. There'll be a short deliberative. But on behalf of the committee, once again, thank you everyone for joining us, and we look forward to seeing you tomorrow. Thank you very much.